We're going? Okay. Nicole operates the prostate assessment pathway at St. Paul's Hospital, and she is crucial. She is crucial in my journey, and she's crucial in helping patients, clients, and families when being investigated and diagnosed with prostate cancer. So I'll turn it over to you, Nicole.
Hello, everyone. My name is Nicole Baba. I work in Saskatoon, Saskatchewan. So today I will be with you to answer your questions that you entered when you registered. I'm sorry I wasn't able to answer all of the questions, but I tried to get to the ones that were most commonly asked. Now, just to tell you that a little bit about myself. So I've been a nurse now for almost 25 years. I've always worked in urology for all of those years. I've been fortunate enough for about the last 14 years to work with patients, their partners and families going through the prostate cancer journey. So what I'm going to share today is the answers that I would normally give. I had to do a little research because I'm not a sleep expert nor an exercise expert, but that's always good for me as well. So let's get started here. Give me 1 second here. This little guy is in my way, the toolbar, so I just have to move it here for a second. I'm not the most tech savvy here. Something's going on. Give me 1 second here. Here we go. Okay. So I'm just going to move my toolbar one more time and we can get started. Okay, so this says the most commonly asked questions. We're going to talk about incontinence, sleep, nutrition, exercise, and much more. That much more being a little bit of our mental health and a little bit about erections. Okay. So the first slide talks about the question of, are PSA readings reliable to determine if a person has prostate cancer? The answer to that is they help us, but they aren't reliable on their own. So the key to understanding PSA is made naturally by all men's prostate. The majority of the PSA made by the prostate goes into the semen. It keeps the semen liquefied so sperm can travel. That's its role. The other thing is some of it will escape into your bloodstream. So that's why we can do a blood test right off the bat. So elevated PSA levels, all they really do for us in the healthcare professional field is they raise a flag that there's some activity in the prostate. Now, what is that activity? We never really know for sure. And so some of the main causes for elevated PSA are an enlarged prostate. Every man's prostate starts growing at puberty and grows your entire lifetime. The size of the prostate you get is really predetermined from the genetics of your parents. And so some men get larger prostates, some men get smaller prostates. And so if a man's prostate is growing more quickly than we anticipate, that can cause an elevated PSA. The second possibility is inflammation. Any inflammation in the prostate will usually elevate the PSA. That elevation is often caused by a urinary tract infection. So that's why whenever we see men, the first thing we're worried about is, are there any symptoms of that? But even if they don't have a urinary tract infection, men can have inflammation in their prostate. They're not aware of it. It's not harmful. It doesn't need treatment even, but it can rise those PSA levels. And then of course, the one we're always concerned about is prostate cancer. Prostate cancer tends to, not always, but usually makes more PSA than normal. So the answer is, are PSA readings reliable to determine if a person has prostate cancer? Not entirely. All that PSA does is raise a flag. Okay, going on to the second question. What are possible symptoms that I may have prostate cancer? And the answer to that is that most men that we see that are diagnosed with prostate cancer, particularly in the early stages, have no symptoms at all. I often have men say to me when I talk to them about their PSAs being elevated, but I feel fine. And I often have to explain that really there's only two camps for prostate cancer, where you feel fine, where it's usually diagnosed with earlier stage prostate cancer, or if you're symptomatic. If you're symptomatic, then it usually is metastatic at that point, which is certainly a camp we want to keep men out of. So signs of that might include troubles urinating, decreased force of the stream, which are also possible symptoms when you have an enlarged prostate. But the other ones are severe fatigue. You have blood in your semen, not only if you have prostate cancer, but for other reasons as well. So that's another one that's a bit tricky. But bone pain, new progressive bone pain, usually within the 6 months, losing weight, and then, just a second, so I just have to move this over a little bit. And then erectile dysfunction. Okay, so the answer is most men really have no symptoms. If you have symptoms, quite often, unfortunately, there is some disease that's already beyond the prostate. Okay, the next question. What imaging tests are used in prostate cancer? So most men diagnosed with prostate cancer really don't need any additional imaging. For us in Saskatoon, the majority of men with low risk are rarely do you order any imaging. Intermediate risk are the sometimes group. High risk, the higher risk there's a cancer outside the prostate. Those are the men that really the imaging are most reserved for, unless you have symptoms of prostate cancer that I just went over. So if prostate cancer is going to leave the prostate, it'll obviously go to the area around the prostate, the capsule of the prostate, into the seminal vesicles, and that's where the semen is stored essentially, and then into the lymph nodes. And lymph nodes, carry waste and nutrients throughout the whole body. And because there's so many of them, hundreds of them all interconnected, that's the first place we want to look to see if we see anything. And that's where a CT scan of the abdomen and pelvis comes in. What we're looking for is enlarged lymph nodes. And then from the lymph nodes, it will often go to the bones. Doesn't mean it can't go to the bones and we miss it in the lymph nodes, but that's usually the progression at the beginning. So a bone scan is most often. So in Saskatoon, those are the tests we will usually order. If there is some unknown, it's not sure about the cancer being outside the prostate, there are some patients will use an MRI. I mean, MRI is a wonderful test. It can help everyone. We can see a lot on it, but they're very inaccessible. And so as a result, we don't tend to use them much. Now, the last test that is in the news and people are talking a lot about now is a PSMA PET CT scan. And that is using a CT and a PET scan to allow us to look at the whole body. That is, very good test. The challenge with the CT and the bone scan, I often talk to men and they'll call me and say, oh, my CT and bone scan are negative. I said, that's great. Great news, let's carry on with some treatment. But we have to be aware that CT and bone scans aren't good at finding microscopic disease. And that's where PSMA PET CT scan comes in. We had a trial in Saskatoon for about 6 months to a year. Unfortunately, our trial is shut down right now because of 2 reasons. COVID, of course, didn't help. Funding issues, and then as well, you have to have a generator to make the isotope at the synchrotron, and we're having issues, getting the generator. So hopefully it'll come back, but for now it isn't. So really, the men that use a PSMA PET CT that qualified for our study were really men with high-risk disease. We want to see, was there cancer beyond the prostate? And really that'll help us to determine, should they be offered radiation, or should they be offered radical prostatectomy removal, or should we do radiation, or should we, go right into, potentially androgen deprivation therapy, anti-androgens and such. The other group that PSMA PET CT scan is very good for are men that have a recurrence after surgery or radiation. Because the big question is always, what should we do next? And really depends on where that recurrence is. So that's where the PSMA PET CT scan is. It is a good test, used widely in the world, but in Canada, not as accessible. I believe the closest place to us in the West is Vancouver. And I believe Ontario has some, but still. And currently, I don't believe, at least in our province, I don't believe it's covered, and it costs upwards of $3,000. Okay, that's it for that one. Now, the next question. How do prostate cancer treatments affect quality of life? So whenever I think about that, I always think of, okay, how do they affect quality of life? What are the things around the prostate that can be impacted that impair men's quality of life? So the biggest organs are the things that are close by to start. Most of us know where our bladder is and our rectum, which is the bottom portion of the bowel. So those organs are called the innocent bystanders, and they can often, unfortunately, receive some radiation. The other is the urinary muscles, which we're going to talk about more, as well as the cavernous nerves. They're tiny nerves that run along the prostate heading towards the penis. So we'll talk more about that. Okay. So the sexual function, so the nerves are what we're first going to talk about. When we think about our male sexual function, we have to remember that most of us now know that unfortunately all forms of treatment in one way or the other impair our ability to have an erection. But erections aren't the only part of your sexual function. The first part is your sexual desire. Our sexual desire is driven by that hormone testosterone made by the testicles. And as long as you're still producing testosterone, you will still have sexual desire. Unfortunately, when you're on androgen deprivation therapy, sexual desire is significantly, if not completely diminished, which makes the other portions of this system more challenging. So as long as you have sexual desire, men can orgasm. Men can orgasm with a hard or a soft penis. It's a separate brain function. If you have a hard penis, of course, it'll be through natural intercourse, floor play or masturbation. If it's soft, it would have to be through floor play or masturbation. Big question men have is does it feel the same? There are many men that tell me it feels very similar. There are some that say it is not quite it's not quite as deep or as good of a sensation, but it's still there. And there are other men that struggle to reach orgasm, be it for one reason or the other, but often because psychologically it's a different change. Ejaculation, releasing semen, which is only really necessary for reproduction. It was a separate event from orgasm. People often think the two are the same, but they just happen to occur at the same time, which makes them a little bit confusing in that sense. So with removal of the prostate, radical prostatectomy, of course, there will be no ejaculate because we've removed those organs that produce and release it. And then with radiation, any form of radiation, it varies from man to man. Many men will find that over time, often years, the amount, color, consistency will change, and it potentially can dry up as well. But remember, ejaculate doesn't give you any better or less sensation as far as orgasm. Now, with erection, that's the huge impact when we look at these treatments because of various reasons. And let's talk a bit about that. So, erections after radical prostatectomy. So this picture here is probably one of my favorites. It comes from Vancouver. They had a booklet for men years ago, and it's very hard to find otherwise. I don't know where it comes from, but so I give them kudos for this picture. So as you can see, the nerves run from the spinal cord across the prostate and into the penis. And those nerves are plastered to the outside of the prostate. So you think about the prostate, the capsule, and then a little bit of tissue. And it's in those tissue that those nerves lay. So when they're looking at, removing nerves, removing prostates, the doctors have to decide, are we going to, allow those nerves to remain attached, cut them at the top and bottom essentially, and take everything out? When that happens, there's usually not much function, if any. But sometimes they will spare nerves, peel them off, leaving the nerve behind. When they do that, they purposely know they have to leave behind that tissue, potentially a little bit of capsule, and always a risk of leaving a bit of prostate. So there's always a risk of leaving cancer behind. So the question is that safe for you? And that decision is made with you and your physician. But the ability to get back erections after prostate removal, really nobody will have erections initially. If they spare nerves, it'll take anywhere from usually 6 months up to two to 3 years until erections may start to return because that nerve's very sensitive and it takes them a long time to heal. So will you get erections back after surgery? The key factor is if you've had nerves spared or not. Your initial erections, if you have good erections to start, of course you have a better likelihood. If they're bad, or if they're not good to start or bad to start, they're not likely to be any better. General health of the patient, age, the younger you are, usually the better chance you have. And then we have to acknowledge that there's certainly research to prove the skill of the surgeon also has a big impact on that. Okay. So after prostatectomy, if a man chooses to want to get an erection, there are a few options, but we're going to talk about that, I think, down the road. So after radiation, so radiation can still damage those nerves. But it also, if you look at the bottom here, it's a more gradual loss. There's some neurological, so nerve damage, there's some vascular damage, there's some muscular damage. The difference is with surgery, I often say it's very immediate, it almost smacks you in the face. And with radiation, it's much more gradual. So this is when I got a little bit ahead of myself. So treatment for erections. If there are any erections that are partial there, then the PDE5 inhibitors like Cialis, Viagra, Levitra, they're the first option. If there are no erections, remembering that those PDE5 inhibitor pill medications, they enhance an erection. So after surgery, you have 0 erections. So 0 enhanced is still 0. So those pills don't usually work. Many men will still try it because they want to, and there's certainly no harm. With radiation, they will often work for months to years, which is something that men favor about radiation, the gradual loss. But really, even with radiation, often those pills will stop working. And once there's no erections, the options are a vacuum device to draw blood in and put a ring on. There's pros and cons to that for sure. The second option is penile injections. I would say that's more commonly sought after by men. Penile injections certainly are a learning curve. You have to be quite highly motivated because you have to learn to inject the medication into the side of the penis. Each time you want to be sexually active, you can use it every other day, up to 3 times a week. You start with a very small dose and you titrate the dose up to where you have a good enough erection for intercourse, but not so good that it lasts too long. And that's one of the concerns about it. If nothing is effective or you can't tolerate it, then the final option is a penile prosthesis. Most places in Canada now have some amount, if not complete coverage for that. And usually men favor the 3-piece where essentially there's 2, you can think of it 2 muscles, 2 rods of muscle that fill with blood when you have an erection. So when they do a prosthesis, they remove that muscle and replace it with saline implants. And that saline will be filled with those implants will be filled, forgive me, because we want to have the shape of the penis. And then when you want to have an erection, there's a device in the scrotum that you pump up. It moves water from a reservoir in your abdomen and to fill those saline rods. And then when you're done, there's a device to deflate it. Again, that's a procedure, so it comes with its own risks. It's certainly not something you want to go into willy-nilly because there's no going back from that. So those are the options to manage those erections. Now, urinary control. This was a big question and a big concern all of you had when you registered, and understandably so, because erections are something that we deal with certainly several times throughout a week, but urinary incontinence is something you deal with daily, often minute to minute even, right? So let's talk first about continence. Well, how do you control your urine flow now? So most men out there right now aren't leaking a whole lot of urine before they have any treatment because you have a very nice urine control system. You have 2 urinary sphincters. The A is called the internal urinary sphincter. That's a big word. I usually just say it's a urinary muscle. Essentially, it's a muscle that opens and closes when you need to urinate. That's really what men rely on. It works extremely well. The second muscle is the external muscle, and that's the red one there on B. That's the pelvic floor. And really men use that when they want to hold back urine, stop midstream. So for most men, their pelvic floor external muscle is not as strong because it simply doesn't need to be because the internal muscle works so well. And then of course, some people will say the prostate is also somewhat of a control mechanism because it does put some pressure along the urethra. So when we talk about procedures, let's talk about how those muscles are impaired or impacted. So with the surgery, you lose most, if not all, of that green internal muscle. So after surgery, when the catheter comes out a week or 2 after for most men, the only way to hold back the urine, because it literally drips into your bladder, as it drips in, it'll drip out because the pelvic floor muscle is what you need to control it. So you go from having 2 muscles to essentially having 1 muscle. So initially everyone will leak. They'll have to wear a full incontinence pad. Men will very gradually gain control. And when I say gradually, I mean weeks to months. There are some men that'll gain control within weeks, but majority of men we tell to prepare for the possibility of really it being 3 to 6 months till you gain control. Even up to a year, there's gradual control. Most of it is within the first 6 months. Some people even say up to 18 to 24 months, we may see some gradual improvement. And that improvement, starts usually at night when gravity is on your side. Over time, you'll start to realize in the morning, hey, I'm dry in the morning. And then as the pelvic floor muscle fatigues, then over time they will unfortunately gain leakage. And then of course, the last time you're going to gain control is when you're doing any strenuous exercise or activity. Now, key player in this all is the pelvic floor physiotherapist. I am always astonished at what they can do for men. I give them a lot of credit in this process. Now, with radiation, one of the nice things with radiation is that rarely will men leak at first. So it's really a very handful of men within the first, 5 or 6 years that'll have incontinence because those urinary muscles are still present, still able to function. But radiation does damage the muscle, the blood supply to the muscle, many things. So over time, men can slowly develop leakage. It takes about 15 years in general till the same amount of men are leaking that had surgery and radiation. So radiation can cause urinary leakage, but again, it's much more gradual. As many of you likely know, the surgery has very similar side effects long-term, but they're often quite early on, and radiation is just, tends to be a little bit later on. Okay, so treating urinary incontinence. This is something that I feel for men because many men go for years without treatment. And there are men that will have mild leakage that live with it. And if they choose to live with that, that's one thing. But if they've got it and they had, haven't had any help or assistance, that's another thing. So any men that are incontinent, within about a year, and if it's affecting their quality of life and they're not able to live with it, I recommend they all seek medical attention with their family physician and or their urologist. Penile clamps are a nice option, particularly as you're still healing. There's lots of different clamps out there. There's pros and cons. People often say, aren't they painful? They can be uncomfortable, but you have to try different ones to find the one that works good for you. If there is enough leakage that you're going through 1 or 2 pads a day and it's affecting your quality of life, then the sling procedure is usually what is considered. If it's more than about 2 pads per day, usually a sling won't get men completely dry. So you have to go to the artificial urinary sphincter. And to put it simple, it's like a little cuff in and around the urinary channel that's filled with fluid to compress the channel. When you need to urinate, because you still have the sensation in the bladder, you have a control mechanism, again, in the scrotum that will move the water from the cuff into the reservoir. You can urinate, and then just naturally within usually about 30 seconds or so, it will start to move the fluid back into the cuff to compress it. Okay, moving on then, looking at my time. When can men resume activity after treatment? So with radiation externally, most men can work through their treatment. Brachytherapy usually takes 1 or 2 weeks. Radical prostatectomy, in the old days, even when I started working, the doctor said 6 weeks, nothing. Nowadays, we say, really, when you're feeling up to it, you can go back to work. Usually you need 2 weeks to recover. 4 to 6 weeks, though, even if you return to work, no heavy lifting, pushing, or pulling. Now, how can I manage the stress and anxiety of prostate cancer? If I had this answer, I would be extremely wealthy because it affects so many people. So, all I can do is help you with options to manage it. Certainly we can't get away with it, can't get away from it. Speaking to other people, speak to your partner, speak to your doctor, speak to your friends, join a support group, speak to people about it. Most people will find some amount of comfort in that. Get enough sleep. Everything is worse when you're tired. We all know that. Stay active. That's easy to say. Active being anything, just keep moving. Take care of yourself. Find ways to relax. Focus on what you can control. There's some things that you can't control, but you still have control of your relationships. You still have control of your health. You still have control of what you eat and how you move. Okay. Now, how do I manage poor sleep? Well, this was a good one for me. I had to do a little research because I'm certainly not a sleep expert, and I learned some information for myself even. So the key for me always is to tell people that you're normal if you're struggling to sleep when you're going through a different time in life, difficult time. Because like I said, everything is worse when you're sleeping. You wake up at 2 a.m. and you start thinking about it, and then the snowball just starts rolling. So tips to help you sleep, try to go to bed at the same time. Wake up at around the same time, particularly as you get into retirement. That can be more challenging, but most people do try to do that. And when you're having this amount of stress, sleep's not good. Try and maintain that. Try not to nap too much. Try and be active. Tire yourself out. Dark, cool room. I mean, not so cool that you're uncomfortable. Try and keep things quiet. Try relax before bed. Don't start researching your prostate cancer, or what you're going to do about incontinence, or how you're going to manage erections at like 9 o'clock at night. It's probably not a good idea. So try and do it earlier in the day. Find ways to relax, be it with music, be it with television, be it with reading, whatever works for you. Avoid alcohol and caffeine. Yes, alcohol can make you go to bed, but it doesn't help you to stay asleep. So try to avoid that. Some protein a couple hours before, and then ditch the devices. That's much easier said than done. I mean, I love to read, but of course it's on my phone or my iPad. And then counseling. Counseling, helping men with mental health is something I've always had a challenge for me personally. I wish I knew more about it. I wish I could do a better job at it. So I often recommend people to go to counseling. Realistically, all of us could use a counselor, but in this situation, it's even more important. And there are medications for sleep, of course. And if that's necessary, you should seek that help from usually your family physician. Okay, next one is what can I do about my mental health after treatment? And I just said it, speaking to others, staying connected with your partner. Sometimes we start to change, we start to lose our erections, and then we don't want to go near our partners, because if we do, then if I go and give them a hug or a kiss, then they're going to want more, and then I won't get an erection, and then I'm failing. And unfortunately, that's a spiral that most men do have troubles with. So try your best to continue to stay connected to your partner, and hopefully somewhat intimate, counseling, and then medications if necessary. Now, diet and prostate cancer. I did a lot of reading, a lot of research to try and figure out the answers to this. Again, I'm not a dietitian, so I'm only going to give you the information that I either give my patients or I've read about and researched. So really, overall, you just want to eat well. That's the key. There really isn't a whole lot of good, firm research to tell us that any specific diet can stop the spread of prostate cancer. There is some soft research, and the BC Cancer Agency offers a very good resource with the Nutrition Guide for Men with Prostate Cancer. That's where I usually direct most of my patients. And if you just Google that, you can often find it, BCCA Nutrition Guide for Men with Prostate Cancer. There's no food that you should completely cut out. There are some patients that will come to me and say, I've cut out all sugar because cancer needs sugar. And how unfortunate if you can't eat chocolate, but still, that's not necessary. You need to eat all foods in moderation, and try and be balanced with your diet. And truly, it comes down to that we need more research in this area to really provide any solid, firm recommendations. Okay, steps to eating well. These were a good reminder to myself. 3 meals a day if you're not hungry, then have smaller meals. All food groups, 5 portions of fruits and vegetables, have a variety of high proteins, dairy or non-dairy because you need calcium. Choose those unsaturated oils, and try to have them in small amounts. Eat less sugar. Again, if we only had something to help make that happen. But it's still, we have to work on it. We're always a work in progress. Cut down on salt and drink your 6 to 8 glasses of fluids a day. Exercise in prostate cancer. Well, it's much the same story. Being active of any kind is going to do you benefit, be it swimming, walking. I mean, realistically, if you research it, they say you should do some exercise where you really breathe deeply, get your heart pumping, and you should do some exercise where you're working hard, but not necessarily, out of breath, such as weight training. And if you can do both of those, that's ideal, but something is better than nothing. We don't know for sure if physical activity will slow down prostate cancer, but we know it's important to your overall health. Realistically, a large portion of men with prostate cancer will tend to die from something else, fortunately. And so as a result, the number one cause of death is cardiovascular, your heart. So I often tell people, eat heart healthy, eat for your heart, and it will naturally take care of your prostate. Okay. And exercising, forgive me. Okay, should one take supplements with prostate cancer? There again is little to no evidence that we know for sure, but it can unfortunately be harmful if there's certain medications that can, cause prostate cancer to grow more quickly. Most people should just try and get what they can from their diet. There are certainly times when your doctor may recommend supplements, and then of course you should take them, things like calcium and vitamin D, particularly when you're on androgen deprivation therapy. And tips for dealing with hot flashes. So again, not a expert. So things like keep your place cool, light clothing, natural fibers, spray your face, warm bath instead of a hot, put a towel on so you can remove it after, cooling pads, like an ice pack. You can try to keep yourself calm, because the more excited you get, the worse the hot flashes. Sipping on cool fluids, reducing alcohol, caffeine, smoking, and just try and stop that. Just try to stop that anyway. Cut out spicy foods, which again, you have to decide if it's worth it to you. Doesn't mean you have to do it. And then there are medications, but I can't offer advice on medications. Maybe your session with the radiation oncologist and urologist can help there. Okay, what tools can I have? What tools can I use to make a decision about treatment? Get the information you need. You need to speak to people to learn what your diagnosis is, what the options are, what the short-term, long-term side effects, what does that treatment entail? That's where we come in Saskatoon. You can just consider a decision aid. A decision aid is basically a booklet or a website that will compare treatments for you. You can get help making the decision from your partner if you have an intimate relationship with your family doctor. Speak to other men. We recommend everyone contact our support group. Don't rush into a decision, and set yourself a time frame. I find that if you say, okay, I will make a decision within 1 month or within 2 weeks of seeing the doctors, to be very helpful. Okay, top things to maintain quality of life during treatment. Learn what to expect. What is your treatment going to entail? Try and keep up with your routine, eating well and exercise. Find a therapist or a counselor or support group, because you need support. And sometimes you even need that outside your family. Ask for help when you need it, and try and reduce your stress, which is easier said than done. And what other health professionals can help me along the journey? So there is the whole list: family doctors, your specialists, your physiotherapists, counselors, psychiatrists, social worker, dietitian, nurses. You have to decide who is going to help you. I had a patient years ago that said he was having a great life. He had retired. He said, I was on the road with the top down. My wife was next to me, and we're enjoying this ride of retirement. And then all of a sudden I found prostate cancer. And it was like I was in a tunnel and it was black. I knew my wife was beside me. I knew there were other men in the same situation in this tunnel with me, but I couldn't see any of them. And when I met you, he said, it was like you brought the flashlight and I was able to see again. So for you, you have to decide who is that person that can bring the flashlight to help you. And what can health professionals do better for patients with prostate cancer? All I can tell you is what I see. We need to do a better job at supporting mental health. We need to be attentive. We need to be accessible. We are possibly over accessible, but we're okay with that. You just phone our phone. We don't answer, you leave a message, we'll call you back within 24 hours. Show empathy, support shared decision-making. Men need to make the decisions what's best for them with our support, and provide consistent care. We need to provide care that's the same across our province. We need to provide support that's the same from nurse to nurse. And that's it, guys. These are my references. I hope you've gained some knowledge or at least enjoyed listening to me.
Thanks. Excuse me. Thanks, Nicole. You were my flashlight, just so you know.
Thanks, Marie.
Okay, we now want to present a community for everyone, support for unique needs, from low risk cancer to metastasis and everything, pardon me, and everything in between. We all know that everyone's prostate cancer journey is unique. So we're going to hear briefly from six specialized group leaders across the country, and we'll start off with you, Phil Segal.
Hello, everyone. This is a group presentation. So I'll just start off with saying that while we have over 60 support groups across Canada, we have groups that are specialized. Not everyone is the same, and these unique groups fill a gap that allows members to seek support that best suits their needs. So Phil, off to you.
Phil, you're muted.
Hi, start again. My name is Phil Segal, and I've been on active surveillance for over 16 years. What is active surveillance? It really is a method of treatment where you're following your low-risk localized prostate cancer, which has a very low chance of growing quickly or spreading outside the prostate. Treatment is obviously not given right away. Your healthcare team is monitoring you and will take an active approach when that situation occurs. Treatment is given when cancer is growing and spreading. The benefit of active surveillance is that it avoids any negative side effects that may arise from various treatment options. Further, there is no evidence for those who opt for active surveillance that they won't live as long as those who take active treatment. I think the evidence on that is fairly strong. The next slide. Why our group on active surveillance is important. We're trying to raise awareness about this underutilized option for non-invasive treatment. Although in Canada, active surveillance is fairly well utilized, it certainly isn't in other countries. We try and encourage newly diagnosed men to review all of their options. I guess we don't proselytize for active surveillance, but we'd like men to gain knowledge before they make a decision. We definitely don't give medical advice, but we do share our own stories and experience. I guess the other two benefits of the group are that it helps those who are on active surveillance to avoid what we'd like to call anxious surveillance. And there's a group camaraderie. I'd like to encourage everyone who is on active surveillance or knows of someone on active surveillance to join the group and help those who are making a decision with their stories. Thanks very much.
Thank you, Phil. And next we have our other Phil, who is the leader of the advanced group.
You're muted, Phil.
I thought I was unmuted. Hi, Phil Segal. I don't meet too many Phils. All right. What is advanced prostate cancer? It includes patients with cancer that has spread, that is metastatic beyond the prostate. Also with a castrate-resistant cancer, or which no longer responds to first-line androgen deprivation therapy, and with a high risk or complex diagnosis. Oftentimes, there are no symptoms, but symptoms can include fatigue, lower extremity swelling, numbness, or tingling, difficulty in urination or frequent urination, loss of weight, a general feeling of unwellness. Treatment typically includes androgen deprivation therapy, or ADT, which is given concurrently with taxane-based chemotherapy, such as docetaxel or cabazitaxel. Cabazitaxel will typically be second line, and docetaxel will be first line. And androgen receptor antagonists, also known as blockers, such as enzalutamide, darolutamide, or apalutamide. And these block the androgen receptor. And then steroidal genesis inhibitors, such as abiraterone, also known as Zytiga, and sometimes radiotherapy to the prostate or prostatectomy and metastasis-directed therapy. This is where they use radiotherapy to treat the distant metastases, and which has shown good results. And support groups, I was not a joiner, but after being involved with groups, I really see their great value. So the support group is a great way for men as well as spouses and caregivers to learn more about cancer diagnosis and standard of care therapies. The community shares the experiences and extensive knowledge of fellow travelers, but does not prescribe. That is something that's very important. Provides a means of finding out about differences in treatment plans between doctors, hospitals, and regions, which can be helpful in discussions with oncologists. I've seen this very often where a doctor in one hospital treats in one way, and there's a different type of treatment in another. They're all standard of care, but there are variations on the theme. Importantly, provides a way to learn more how other men cope with their diagnosis, the disease, the side effects of therapy, and which can be very useful in improving one's quality of life. How does that person cope with and manage the trauma of being diagnosed, and how do you manage the side effects? And finally, there is this uplifting camaraderie quite often, so it's very useful.
Thank you so much, Phil. And next we have our next support group leader for partners in prostate, Glenda.
You're muted, Glenda. Sorry.
All of us have done that. All right. So hi, everyone. It's nice to be here. I am happy to say that I am the facilitator, and thank you, Rochelle, for inviting me to be that for the group, because it is very important. My husband was diagnosed with prostate cancer in 2011 and had a radical prostatectomy in 2012. So for me, this is very important because we know that it's one of those things that we have at our disposal now, because the wives go through it as well as the husbands. And I think that was a really big link that was missing. So our support group for partners, the partner of the prostate cancer patient takes on the role of the primary caregiver. And in addition to taking care of the patient, the partner may also take on the roles of patient that they can no longer do. So the treatment decisions usually made with partner in mind or discussed with them. And the side effects of prostate cancer do affect both the patient and their partner. And I think that was a lot of times not paid enough attention to, that we go through it with them. Having been both a cancer survivor myself and the cancer caregiver, I know it's a whole lot harder being the caregiver when you're helping someone through their own journey. So that's why our group is important. The prostate cancer is often referred to as a couple's disease, and that is so true. It's due to effects on sexual function, due to effects on intimacy, and the whole change in a man. My husband said, I don't know what was in that walnut, but when they took it out, I can now cry at a commercial. So there's a lot of changes that happen to the couple. And our group is a safe place for partners and caregivers of prostate cancer patients to share their experiences and concerns, and be able to ask things in a safe environment that they can't talk to their family about, especially their kids. And the caregiving, the grief, the fear of losing a loved one, and etc. And also the camaraderie. We have a really strong group of friendships happening in our group. So it's very important.
Thank you so much, Glenda. And next we move on to the Walnut Foundation with their Vice President, Anthony Henry.
Hi, my name is Anthony Henry, and thanks for inviting our group to be a part of this presentation today. We are Black Men's Health Interest Group. We address multiple health issues, but the main focus has been over the years prostate cancer. Sometimes we find that it's not so easy to get our men to talk about prostate cancer. And so it might be easier to connect with them where they are. And if that means talking to them about something else, then we go at it that way. So while the focus is on Black men, men of all races and ethnicities are welcome to our meetings and events, and you often find that when we go out into the community. The idea is to create a safe space that's culturally appropriate for Black men to discuss issues specific to their particular situation. So we hold awareness events and support research to improve outcomes for Black men. So, we are dedicated to education and support of Black men and the broader community, and basically to encourage men to be more empowered to take responsibility for their own health. So why our group is important? Black men are 76% more likely to be diagnosed with prostate cancer than other Canadian men.
Yeah.
And are 2.3 times more likely to die from this disease. In fact, a study that was done a couple of years back really brought that home to us. And that's why we've been doubling down our efforts to educate our community about this. There are socioeconomic factors, and of course, there's misinformation. And that presents barrier to early detection. So oftentimes what you find is a lot of our men engage with the healthcare system when their disease is far advanced. We don't provide medical advice, but we do share our experiences or try to point the men in direction, where they can get credible information. And the other part of it, of course, is to provide the camaraderie, because going through a diagnosis, going through the whole treatment can be a solitary kind of existence.
Thank you so much, Anthony. Very much appreciated.
Thank you.
Next, we have our Richmond Prostate Cancer Support Group founder and leader, Daniel Leung.
Good morning and good afternoon, everyone. We are a Chinese-speaking support group. We speak Cantonese, Mandarin, and English. Everyone are welcome. Because we know the Chinese culture, and also we know the traditional Chinese medicine, so we can help all the Chinese community. We distribute the Chinese booklets, also the resources, and also we maintain a Chinese and English website that is chineseprostate.com. We also outreach to the community, to the Chinese community. We attend all the local Chinese health fairs. We go to the public libraries, and also we go to the community center to set up our education booth. And also we operate a walking cup. We walk twice a week. Every time we walk 10K in 2 hours, because we have a very beautiful river dice in Richmond, BC. And why our group is important? Because the Chinese community, the most large spoken English in Canada, is about 5% population in Canada. Most of the seniors, they cannot speak English or French. They use their mother tongue, Cantonese or Mandarin. And also they are very hard to reach the health and the medication supports. But we can share some information about that because we have a Chinese speaking volunteer advisor. He's a registered nurse, so he can provide some health and diet concerns answers. So also we have some nationwide Chinese TV and radio and the newspaper, and also there are some social media group, the Chinese social media group, they can help us to promote the support group. Now we have 280 members on the list. Also, we are serving the Chinese-speaking patients from other provinces via the phone call or the message device or the email. And also, because we have a walking club, we have the social media to help, so we can uplifting the friendships with all the patients. Thank you.
Thank you so much, Daniel. And last but not least, we'll have our Butts in a Boat Vancouver leader, Vince Schiralli, talk about Butts in Motion.
You're muted, Vince.
I thought I unmuted myself when I was going to be special, but and am I going good now?
Yep, you're good.
Thanks very much. Okay, well, thank you everybody for tuning in. The question is, what is Butts in Motion? We're a prostate cancer fitness group that supports camaraderie and really fitness. In our case, patients and their partners are welcome. We basically are open to all individuals interested in getting fit. We began back about 7 or 8 years, or 7 years ago, as a Vancouver prostate cancer dragon boat team. It was the first of its kind, we believe, in the world, made up of entirely prostate cancer patients. And we've expanded now to offer a wide variety of activities. In addition to our dragon boat team called Butts in a Boat, we also have twice a week fitness classes. We have walking clubs, butts in yoga, butts on bikes, biking teams. So we have a variety of activities with the whole theme of trying to stay fit and trying to stay supportive. You know, why is our group important? Well, there's no question. Research has shown that there are many, many benefits that exercise can provide to a prostate cancer patient. I always say that cancer doesn't grow in a healthy body as easy as it does in one that isn't so healthy. And so creating a vessel that is tough for cancer to grow is I believe, an important thing. You know, there's social and mental health benefits associated with this. I mentioned, you know, we have all kinds of guys from early stage active surveillance all the way to, you know, later stages. But the camaraderie that we get, there's some pictures of some guys in Noel there doing stretches. You can see that we're not the most fit people all the time, but we're giving it our best. The group activities make fitness more sustainable than exercising alone. We exercise in the winter when we can't do the butts, the paddling twice a week over Zoom. And it's interesting how you feel kind of looking at your watch. It's 4:30. I got to get over there because my buddies are exercising, and you do too. And honestly, it really does work. We don't give medical advice, but we do have some people who are at all different stages of prostate cancer. They share our stories, we share our experiences. We spend 30 minutes at the end of our fitness exercises, just talking about anything and all things. Again, including social activities. We now have dinners together. We've become a family. We have about somewhere between 40 to 50 people who join us on a regular basis for our variety of, and we're all open to anybody. We have people from Ontario. We're BC based, but we have Ontario, Alberta, people who are coming in on Zoom. So we encourage you to look us up under Butts in Motion and join the group. Thank you very much.
Thanks,
Thank
Vince,
you.
and thanks. Oops, sorry.
No, go ahead, Murray.
Okay. Thanks, Vince, and thanks everybody else. That just shows how unique the prostate cancer journey is and why all of these groups are so important. Now we're going to move on to something that a lot of us struggle with, how to find trusted information. Dr. Richard Wassersug earned his PhD in evolutionary biology, earning an IG Nobel Prize for his study on the comparative palatability of tadpoles in Costa Rica, whatever that means. After being diagnosed with prostate cancer, Richard turned his research interest towards the psychology of prostate cancer. He's now the co-lead of the National ADT Educational Program and the lead author on the book Androgen Deprivation Therapy, an essential guide for prostate cancer patients and their loved ones. Welcome, Richard.
Thank you. And I am unmuted, I believe. You can hear me. I'm going to try to share my screen. That's not the screen I'm looking for. The screen I'm looking for is my PowerPoint presentation. And can I move this screen and see my PowerPoint presentation? Okay, it's not working. Maybe I'm missing something here. Share. Let's try hitting share. And let's close that. I am sorry about this. Hit PowerPoint. And live transcript, close caption. Close that. Close that. Hit that. And that's the end of my slides. Let's go to the beginning. I'm sorry for these delays. Let's get... All right, I'm going to try to catch up here. Now, can you all see my slides and can you all hear me? Somebody say yes.
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 All right. I don't know how to minimize the script that's on my, whoops, the screen there. That's, darn. Okay, so we're running behind already, so I will blast through this. First of all, I want to thank the organization for inviting me and sending me a shirt, which doesn't show up on the screen very well, but that's, I'm not wearing it because I usually lecture with bow ties, so that's me. I am an academic, and I spend a lot of time doing research. So I have a few key themes and topics. I'm going to talk about strategies to find information that you can trust on what that's up to date, by me trustworthy, up to date, comprehensive, and authoritative. I want to talk about tricks to using Google, warning signs of an unreliable site, and things to consider when conducting searches, and PubMed, and how to get access to medical papers and the authors of papers, and some case studies. So I've got about 6 key points. You need to know when and how to use Google versus Google Scholar. So Google Scholar is a special subset of Google. Anybody can reach it, and it is the academic papers. So if you want to know something about, has anybody published on asparagus and prostate cancer, you can go to Google Scholar, put up asparagus and prostate cancer, and it will get you the academic papers, not just anything that someone might have mentioned, but the academic papers. All right, you need to know when to use quotes. Using prostate cancer as an example, about 5 years ago I did this, but I could update it. If you put the words prostate cancer in without quotes, you're going to get 29. Back then I got 29 million hits. If you put prostate cancer in quotes, then it looks for not the 2 words separately, prostate and cancer. It looks for those 2 words in combination. So if you're looking for androgen deprivation therapy, and you put in the 3 words separately, it's not the same thing as putting quotes around androgen deprivation therapy. And this is an example. Prostate cancer treatments get you 9 million hits, but if you put it in quotes, prostate cancer treatments cuts that by 1/3. So using quotes is a powerful tool. Using quote marks cuts the number of hits to 1/30 of those required using just 3 words prostate cancer treatments. Start with long strings of words. So if I'm trying to find out, and my area of interest is hormonal therapy or androgen deprivation therapy, I try to think of all the words that might be related. Cancer, prostate, hormone therapy, testosterone, side effects, treatments, hot flashes, right? That's a lot of words, but I try a long, long string. Okay, those 10 words still get you 1.35 million hits. However, and this is interesting, if you start with a long string, you might get what you're really after. And indeed, it got to a site called Prostate Cancer UK, which is, I consider outside of Canada, the best national support prostate cancer organization in the world. They are fantastic. So here you go. We took a long, long string. You don't pick one word, you take a long string. And if you do it right, and that's Prostate Cancer UK, it is very credible. So starting with long strings. Moving on, the next 6 hits I got on that search, and I'll run them through, it was www.cancer.net. That is the American Society of Clinical Oncology. That's ASCO is the top research organization for clinical research in the world. So that's reliable. Next one is www.cancer.gov. And that's the National Cancer Institute in the USA. So just by starting with a huge long string of every word I could think of. Now, if you start a huge long string and you get nothing, then you have to drop words out. But keep on going. And the next one, this is all the top 6 I got out of that, like, whatever it was, 100,000. The next one was American Cancer Society. The next one was the Mayo Clinic in the US. The next one was Health Union LLC, which is an organization, not a corporate organization, but nevertheless very credible. And lastly, University of California, San Francisco. So there you go. Use quotes, use Google Scholar, and use long strings. All 6 that I got for my first hit on those long strings. One is commercial, but all the others are not, and all of them are nevertheless credible. Now, the next thing, point 4, who is sponsoring the site? So what we call the extension at the end of a URL, that's a universal locator for essentially an internet address, tells you what type of organization it is. So if it ends with a .com, it's a commercial organization. They're probably trying to sell something. If it ends with .edu, it is a U.S. educational institution. So that could be University of California, could be Harvard, it could be New York University, whatever. But it will be an educational institution and usually reliable. For network infrastructure, it's an unusual thing to pull it up, but occasionally, if you do a search on something leading to a background, a bogus site that's using a front, sometimes you hit a net extension, and they suggest that something's a little odd and not typically reliable. .org is originally for non-commercial organizations. It's now not as restricted, but typically the .com is commercial, a little suspicious. .edu reliable, .org reliable, and if you haven't run into this before, .xxx is indeed pornography. Then if that's what you're looking for, then look for the XXX extension. Other things to consider: check the ads in the margins. Note that organizations can pay to be pushed high up or positioned high up in Google. So sometimes commercial stuff will show up in the margins, or you can spot that, but it will say .com typically. But well-visited sites come up early too. So that's how you get the Prostate Cancer UK, the ASCO, and NIH, and so forth. They will come up early on a good long search. And then this is a really important one: read the disclaimers. So often sites will go through pages and pages and pages. And if you're not sure it's reliable or not, go right to the bottom and look at what it says at the very bottom. Because if they're marketing something, but they don't want to get caught in a legal battle, they're going to say, well, we're not really helping you. This is just for educational purposes. This isn't really cancer advice, even though everything for the pages before may have been ads for their organization. Chase down in Google Scholars the authorities of named sources. So often patients say, how do I find out about this? And if it's a paper that you pulled up and it has authors, there are ways of finding the names of the authors and writing them. Suppose that 2 sites have disagreements on their recommendations. So you dig up and you see if you can find a date when the site was last updated. So I've seen sites that sounded so authoritative, but they were 8 or 10 years out of date. All right, so you look for a date on there and you can usually find one. Find out what MDs and PhDs. So we're looking at an organization like Prostate Cancer UK. You can go to their directory of who's on their board, who are the managers of the organization, who are the funders, and so forth. And usually organizations.orgs will have that information. And if you're looking for reliable information on prostate cancer, you would expect to have a lot of, or at least some, researchers and MD, PhD scientists who work in prostate cancer. So research their board. Find out how many really credible, authorities they have backing them up. And that's one way of, again, assessing their reliability. And use that information to decide who to trust. So I'm blasting through this quickly because so here's some warning font signs about things not to trust. There are some words that are soft, sound right, but don't have a lot of authority behind them. They're not part of what we call evidence-based medicine. The words holistic, natural, and herbal are always scare me. Patients should understand that real medicine that's done by randomized controlled trials, that is real, well-designed research, is the backbone for evidence-based medicine. So if you want to know is it reliable or not, and they tell you we offer you a holistic, natural, herbal cure, That's not the same as saying is here's some references. These were randomized controlled trials. I'll tell you more about where you can test where to find those randomized controlled trial studies. Okay, so the ones that use those words should be realistic. One should be realistic about whether we're talking about holistic medicine, alternative medicine, or naturopathy. And that's going to be less reliable than evidence-based medicine, because evidence-based medicine depends on research backing it. The evidence comes from the research. So I'll mention something here. There's a wonderful little YouTube video called Storm, and it's a little sort of hip hop poem by this this comedian who loves science. And he talks about, he gets into a conversation with someone, he gets flipped out because they're endorsing alternative medicine. And mentions says evidence-based medicine is medicine that has either not been proven to work or medicine has been proven not to work. Alternative medicine that has been proven to work is simply called medicine. So alternative, natural, herbal, holistic, all those things are things to be suspicious about. Be suspicious of sites with testimonials. Now, that's not necessarily true if you're just trying to buy a rug, a household appliance, or pick a restaurant. But when coming to cancer, it does matter whether we're looking for testimonials. When it comes to cancer treatments that have not been proven effective in randomized clinical trials, those RCTs, testimonials should be treated with suspicion because they will be biased. Simply stated, cancer patients who tried the treatment and it didn't work typically aren't around to provide testimonials. So that's a little glib, but it is a situation. That is, if we're dealing with things that could affect our life and death, and someone says, I thought this was a wonderful herbal medicine, I felt so much better. We don't know how many people took it and didn't survive to post a testimonial. If the site includes video clips and background music, if they are flashy, they are even more suspect. Okay, so this is, I put a slam against these words like holistic, natural, herbal, cancer. So I ran it to try it out. I put those words in to a site and I got this one, cancerresearchawareness.com. Well, com says it's commercial, but is it really? What is it? And if you go to the front of the site, it says, we've searched and compared Mexican cancer clinics for 9 years to locate what we feel is the best of the best natural alternative cancer clinics in the world. And it's found in Tijuana, Mexico. Now it goes on and on with pages, with testimonials, but if you get to the very bottom, the small print, after they're trying to get you down to their clinic in Mexico, if you check out the small print disclaimer, it says, in quotes, because they have to do this legally to keep out of trouble, this site does not provide medical advice, diagnosis, or treatment. After you've read all those pages where it's trying to tell you that it's found the best of the best of a cancer treatment. So be suspicious of those words and scroll to the bottom, because that's where you're going to find the legal protection from whatever they're trying to push. Okay, know how to use PubMed. So PubMed has this website, and it is the National Library of Medicine at the National Institute of Health in the USA. And it will post the abstracts for papers that are from the evidence-based medicine from those clinical trials. And you can get them there, and anybody can access it. So this is, if you have a question about, as I said, example, asparagus and prostate cancer, you could put it in and you will get the hits, all of the evidence-based papers. And typically the abstracts are readable. PubMed comprises more than 34 million citations for biomedical literature from Medline, life science journals, and online books. Citations may be include links to the full papers, which can be then accessed through PubMed Central. That is, often you can get the whole papers for free. Okay, a few more tips. The medical literature on cancer is so voluminous and the field is changing so fast that one should not expect family physicians to keep up with it. So I've heard a patient complain, my doctor didn't even know about this. Well, the doctors are trying to treat all sorts of illnesses. They're all overloaded, and you can't expect them to have the time to both treat you and read literature at the rate that it's coming out. And more us patients are doing the research ourselves. So again, I'm talking now to help you come up with ways to do this research. Some of the medical literature is actually written by drug companies who then get MDs to co-author their papers. So now we have a concern. So you can look into a paper, you can look at who they acknowledge, and look if you see if the drug companies are acknowledged for actually helping or being authoring the papers. Even the best websites that are not for profit and are committed to helping patients may not be comprehensive and up to date. So also look at the dates, and you can often scroll and find a date when they last updated the site. And good papers, good data appear in peer-reviewed publications. So when someone says, I don't know where to find information, I went on Google, I want to know, did you go to Google Scholar, which gets you the academic papers in general? Did you go to PubMed, which gets you the medical academic papers? Because that's where you want to go to get reliable information. All right, peer-reviewed means that experts really read the paper. Now there's flaws in the system, it's not perfect, but it's a lot better than having a commercial people sort of trying to write something that looks scientific in order to get your money for their herbal mix. Research papers listed in PubMed are typically peer-reviewed. For journals to be listed there, they have to meet that and other rigorous standards. So PubMed is a source of reliable information typically. In contrast, most books on cancer are not peer-reviewed. So typically people think, wow, this book is huge. That paper is only 5 pages long. But if it's a huge book, doesn't mean it's reliable. It wasn't necessarily peer-reviewed. A book may look more authoritative because of its size, but quantity, that is the size of a document, does not necessarily reflect quality or reliability. Okay, so final comments. Many booklets and pamphlets given out by doctors' offices and cancer clinics are drug company products presented as educational materials. That is not necessarily bad. It depends on what they write and who wrote it. And many nonprofit organizations, and I'll admit it, we run a national androgen deprivation therapy educational program, and PCF BC, who's sponsoring this talk itself. We are both supported by industry, but you notice we're not advertising. I mean, that is, we're not pushing their products because they legally in Canada can't support us if we are pushing their products. We have real ethical boundaries on that. But so it isn't necessarily always bad that we get pharmaceutical and industrial support. It is bad if they're writing the papers and hiding it. In conclusion, trust PubMed in general. Trust Wikipedia, by the way. This is another thing that's fascinating. Someone said, I read about this drug. I don't know anything about it. Check it out on Wikipedia. It's usually in common English, accessible. That's a good starting point. Wikipedia is a pretty darn good encyclopedia. But be suspicious of treatments that don't have a good track record in the medical literature, i.e. are not listed in PubMed. A few moral tips. Books are big and solid and may thus seem more substantial and credible than websites, but they're not peer-reviewed. Consider suggestions offered by other patients or prostate cancer chat groups as suspicious, even though we're talking about it here today. It can be suspicious if people post them and can't provide citations. So I participate in a lot of chat groups online about it. When someone's pushing a product, a herbal mix, and they won't give you their name, they don't give you a citation, I get suspicious. And lastly, if you want to know about the latest treatments that are under investigation, the ones that haven't been published yet because they're still active, you can go to a site called clinicaltrials.gov. It's a little awkward search engine, but it gets you to the tens of thousands of clinical trials, not all in cancer, but all over the place. Clinicaltrials.gov lists clinical trials around the world. So it's a place if you've got an odd situation, you want to know, is there a clinical trial that's reliable? Clinicaltrials.gov is a place to go. And I think to Rochelle and Meyer, I think I put you back on time. I don't know if I have time to questions or answers, but I post my email address. I may be shooting myself broadly for this, but if someone says, I read this, is this reliable? I might say, I'll try and investigate it for you. But if nothing else, I would like you to at least try Google Scholar, PubMed, as starting points. Thank you very much. I'll stop there.
Thank you, Richard. That was great. It's so hard to find vetted information, and I think that's just fantastic. So we're going to take a 10-minute break for a cup of coffee or a bathroom break or whatever you need to do. So set your watches and come back in 10 minutes, everybody.
Okay.
we are going to now take a short yoga break with the Butts in Yoga instructor, Sharon Freeman. So take it away, Sharon.
Hi. Good afternoon, everyone, or morning, wherever you are. My name is Sharon Freeman. I am the instructor for the Butts in Motion yoga program. I'm very happy to be with you today. So about yoga, yoga is known to or can enhance the quality of life in cancer patients, not just cancer patients, but any of us really. Up to 30% of prostate cancer patients experience anxiety, fear, and distress surrounding their disease and treatments. In addition to improving overall fitness and flexibility, yoga may be particularly beneficial from a mental health perspective. It encourages mindfulness, which has been proven to be an effective practice to lessen anxiety and stress. So in our sessions, we do focus on core and pelvic floor exercises. So pelvic floor exercises within yoga may also benefit patients dealing with incontinence or sexual dysfunction. In general, regular fitness and exercise has been proven to be the single best thing you can do for your prostate cancer, aside from recommended pharmaceutical interventions. Getting yourself moving at least 150 minutes a week is so important. You can break that time down into whatever chunks of time are feasible for you. So if you exercise or practice yoga with your loved ones to make it more fun and sustainable, that's a really good way to do it in a group or a small group or virtually. For more info on exercising with prostate cancer, or if you wish to join Butts in Yoga program, visit buttsinmotion.ca. All right, thanks. So having said that, from where you are, I'm coming back. I just need a sip of water here. From where you are, if you come forward on your chair so that you're not leaning back on your backrest, think about pulling your spine up nice and tall. And then just simply send your shoulders back and down. So you're going to draw your navel in a little bit and think about you're stacking your spine one vertebrae at a time, making yourself very tall. Think about some length coming into your neck and feel the top of your head or the crown of your head being drawn up towards the ceiling. So now we're going to draw our focus to our breathing, to our breath. I want you to try and visualize your lungs as a couple of balloons. And as you breathe in through your nose, just try and think about how much space you can fill within your lungs on your inhale. Let your chest and your belly and your side body and your back body open up to accommodate your inhale. When you're ready to exhale, slowly press the air out through your mouth as evenly as possible. And I want you to just focus on your breath and feeling what's happening in your body when you breathe more mindfully with intention. Sometimes it helps to have tactile feedback. So if you place your left hand over your heart, your right hand over your solar plexus or your belly while you're sitting up nice and tall, as you breathe in, you can feel your front body opening up into your hands. Then visualize those lungs filling up as you inhale. And go ahead and exhale. Good. So now you can just place your hands on your upper legs, or if you want, if you have room at your sides, just let your arms rest at your side body. And you're just going to move through the neck a little bit. So if you start by inhaling with your gaze fixed forward, then slowly turn your head to the left as far as your neck will allow your head to turn. Inhale back to front center, fix your gaze forward. Nice deep breath in. And on the exhale, turn and look to the right as far as your neck will allow your head to turn. Good. When you're ready to inhale, slowly bring your gaze back towards front center. So we're just going to do that a couple more times, just turning our head to the left and to the right. So inhale first before you move. And exhale through the mouth. Keeping your spine nice and tall. As you inhale, bring your gaze back to the front. And then exhale. Good, gaze back to the front. So we're just going to slowly lift the chin and fix our gaze upwards as we inhale, getting some stretch through the front of the neck and into just underneath the low jaw. So leave your jaw parted, and then when you're ready to exhale, tilt the chin down and tuck the chin into the chest. Maintain a nice tall posture. And again, breathing in and lifting the chin. Just go as far as comfortable for you, looking up to the ceiling if you can, getting a little bit more stretch to the front of the neck. And then when you're ready to exhale, bring your gaze down, tuck your chin into your chest. Feel the stretch in the back of the neck on either side of your cervical vertebrae. And then feel that stretch coming down into your traps. Try and depress your shoulder blades. And then bring your gaze back to front center. Have your feet firmly planted on the ground. Hopefully you have room on either side of your body. If you have a armrests, you can probably work around those. So you're going to take a deep breath in and then just simply inhale your right arm up and stretch up, reach up towards the ceiling. And then exhale, just float that arm down. And then inhale the other arm up, reach up. And exhale it back down. Now we're going to bring both arms up. Inhale up, reach, stretch, lengthen, and exhale down. Good. A couple more. Inhale up. And exhale. Good. Two more. Stretch, lengthen, and exhale. One more. And exhale. Good. We're going to come into a bit of a spinal twist now. So you're going to take your left hand and take it on the outside of your right knee. If you can reach around to the back of your chair, just hold on or lever yourself into the right side of the backrest of your chair. And then you're going to pull into your right knee and start to twist and look behind you over your right shoulder as you exhale. When you're ready to inhale, bring both hands and arms back around to the front. Take your right hand on the outside of your left knee, take your left arm and just grab around to the back of your chair and twist and turn and look behind you. Again, a little bit of spinal twist there. When you're ready to come back to the front, come back, reset. Nice deep breath in. And if you don't like too much of a twist, then just place your right hand behind your back on your seat. Press your hand down into your seat and then twist. Inhale to come forward and then exhale, twist. Good. Next, we're going to go through spinal extension and flexion. So as you're seated at the front of your chair, I'm just going to turn sideways so you can see. I'm going to just place my hands on my upper legs, just in front of my knees. And as I inhale, I'm going to pull my shoulder blades back. I'm going to open my chest up towards the ceiling, fix my gaze up, tilt my tailbone back a little bit so that I'm coming into spinal extension. And then when I exhale, when you exhale, we're going to go the other way. So you're going to tuck the tailbone under a little bit, roll the head down, tuck the chin down towards the chest, scoop your belly a little bit. If it helps, you can open up your arms in front of you as though you're hugging a big barrel. Just really round out your arms so you can create space between your shoulder blades, and then come back into your spinal extension as you breathe in. So send your chest forward and the top of your chest upwards. Lift your chin, breathe into your body, open up your body with your breath. And then as you exhale, we're going to go into spinal flexion around the spine, create space between the vertebrae. Use your arms if it helps you round out a little bit more. And think about creating space between your shoulder blades. Tilt the chin down. Good, a couple more times. So you can just keep your hands on your upper legs if that's better, and then just go inhale and exhale. So a little bit quicker movement, inhale and exhale. A couple more, just moving through the spine, inhale and exhale. Good, and since you've probably been sitting for a while now, if you open up through the front body a little bit, you can interlace your fingers behind your back, just at the low back, and open the chest, roll the shoulders up, back and down, open the chest, and then extend your arms slightly back into the back of your chair and feel the stretch across the front of the body. Stay here for another breath in and out. So nice deep breath in and exhale out. And then reset those hands onto the tops of your legs. So hopefully you have room to stand. So from here, you might, if you have a chair, you can just move the chair back so that you can stand nice and tall. And I'm going to turn around and so you can see what's going on in the back, because we're going to get a little bit more stretch into the sides of the neck. So standing, you're going to grab your right wrist and pull it over towards the left. And you're going to create some stretch across the top of the right of the shoulder and into the side of the right arm. And then you're going to tilt your head. So send your left ear down over top your left shoulder and feel that stretch coming into the right side of your neck. And think about that stretch and feel it extending down into your trap muscle and across into the top of your shoulder a bit more. So by pulling the right wrist over to the left a little bit more and tilting your head down, you can get more stretch in that side of the neck. So slowly, gently release the grip on the arm and the hand, release those arms down, just give them a shake, set your gaze center forward again. Then you're going to take your left wrist in your right hand and gently pull that arm towards the right side. Nice deep breath in, and then as you exhale, slowly let your right ear come down over top your right shoulder, creating a nice big stretch in the left side of the neck, coming down into the left trap. Good, so let's do that a couple more times. Standing, or if you have room seated, you can do it seated. So holding onto your right wrist, gently pulling it over to the left side. Nice deep breath in through the nose, and then when you're ready to exhale, let that left ear come down over your left shoulder. Good, bring your gaze back to front center. Switch sides, nice deep breath in through the nose. And good. And then we're going to do a partial spinal roll down. I think we're just about done here, right? So standing nice and tall again, you're going to pull up through the crown of your head as you inhale. And as you exhale, you're going to start to roll down through your spine. So start by tucking the chin into the chest and release through each vertebrae. As you come down, let your fingers slide down to about where your knees are. Feel some opening come into your T-spine and your L-spine. If you have room to go lower, let yourself all the way down, let your arms hang heavy from the shoulder sockets and let your head hang heavy at the top of the head. hang down towards the floor. Before you come up, you want to breathe in again, open up your body with your breath. And then as you come up, draw your belly button in, you strengthen your abs to come up one vertebrae at a time. Chin into chest, and the head will be the last thing to come up. And as you come up, pull those shoulders up, back, and down. Good, one more time. Nice deep breath in. And as you exhale, you can come down just part way, or if you have room, you can go all the way down. So you're gonna just release through each vertebrae one at a time, articulate through each vertebrae, create space between each vertebrae. And as you get down closer to the floor, for those of you that have room, let your arms hang heavy, let your head hang heavy. Feel the back opening up. Feel the backs of the legs getting a bit of length into them and your glutes as well. Nice deep breath into your body. And as you exhale, draw the belly button in and then slowly start to come up one vertebrae at a time. Chin into chest. And head is the last thing to come up. Shrug those shoulders up, back, and down. And then go ahead and have a seat again at the edge of your seat. Feet firmly grounded and shoulders back and down. Good. So one more time, let's go into a couple twists. Nice deep breath in. Exhale, twist. Nice deep breath in. Exhale, twist. Good. So let's seal our little practice, our short yoga practice with a nice deep breath in. As you inhale, float those arms and hands up towards the ceiling, palms together at the top. And as you exhale, bring those hands down to your heart center. Namaste. Thanks for joining me.
You're muted, Murray.
For crying out loud. Sorry about that. Thanks, Sharon. You
You're
can catch
welcome.
Sharon and the other Butts in Yoga for free sessions every Tuesday at 3 o'clock Pacific through Zoom at buttsinmotion.ca. Now we're going to go with Dr. Linda Carlson speaking on managing anxiety and difficult emotions with mindfulness. Dr. Carlson holds the Enbridge Research Chair in Psychosocial Oncology from the University of Calgary. In addition to her many renowned rewards and prizes for work in this area, Dr. Carlson's research in psychosocial oncology, integrative oncology, and mindfulness-based cancer recovery has been published in many high-impact journals and book chapters. And she's published a patient manual in 2011 with Michael Speska entitled Mindfulness-Based Cancer Recovery, a Step-by-Step MBSR approach to help you cope with treatment and reclaim your life. Welcome, Dr. Carlson.
Let me just check. We're about 15 minutes behind. So do you want me to just do a half hour or 45 minutes?
Rochelle?
Great question. I think we had built in some time for questions. So maybe if we just skip that part and you do your half-hour talk, if that's okay.
Okay.
Perfect.
Thank you so much.
As long or as short as you want. All right. Well, thank you for inviting me. Happy to be here today. And thank you, Sharon, for that nice yoga break. That's definitely part of the work we do with our mindfulness-based cancer recovery program. So I'm going to talk about the cancer experience broadly from a psychosocial perspective, tell you what integrative oncology is, something we call the mix of 6 to keep in mind, and then specifically around stress management through mindfulness-based interventions, and ours is called mindfulness-based cancer recovery. And then if we have a bit of time, I'll show you some breaths, sort of different types of breath work you can use to help yourself balance your breath and relax, called minis. All right, so most of you on this call have been through a personal experience of cancer, so you kind of know about what it feels like. But when we talk about it more academically, I guess, we talk about the central features being things like loss of control, right? All of a sudden, you don't know what's going to happen with your life, how things are going to pan out. You know, everyone sort of had it all laid out, how we thought things would happen, and now it's all kind of thrown up in the air. Of course, when you hear that diagnosis, you think about your life and if it's going to be foreshortened and your potential mortality. That comes to the forefront. There's a loss of certainty, predictability, and routine. You know, you may have to take time off work or early retirement and have treatments you don't know, every day or how often that's going to go. There's many emotions people often feel, including grief and loss, fear about the future, anger, perhaps, why me? There could be self-blame or shame, depending on the type of cancer or the causes, and sadness and depression. And lots of symptoms people often experience, including pain. Fatigue is the most common symptom, difficulty with sleep, what we might call chemo brain or brain fog, cognitive problems. And then no matter how good the prognosis, there's always a fear of recurrence. Every ache and pain might get your mind racing. What does that mean? Is it, a sign that cancer is progressing or coming back? There's this term scanxiety we use when, every time you have those follow-up treatments and you have to get tests or scans, there's a lot of anxiety surrounding what the results are going to be there. And of course, for caregivers, there's an equally difficult transition period of coping with cancer and sort of transitioning to that role as caregiver. So when we talk about anxiety and depression, which are kind of the most common emotional experiences in cancer, there's certain risk factors to keep in mind for people who are high risk for that. So if you've had a history of mental health problems like depression or anxiety, you're more at risk for that during cancer. If you already have poor sleep, difficulty falling asleep, getting up at night, that's a risk factor. If you're someone who's really has intense reactions to stress, you're very emotional, that also can put you at risk. If you're someone who tends to worry and ruminate a lot anyway, if you typically sort of try to avoid coping with difficult things, and kind of escape the situation or run away a little bit, that tends to be not as helpful. If you don't have as much social support or there's tension in relationships. And if you're socially isolated, which has gotten a lot worse in this era of COVID, social support's really important. There's just a good reference there from a clinical psychologist I work with. And I'll share these slides with you afterwards so you can get all the links and references. So I want to talk to you about integrative oncology and what that is. I noticed Richard in this talk sort of touched on this. I'm going to talk a little bit closer in a bit more detail. Integrative oncology, we define it through the Society of Integrative Oncology, where I'm actually the president at the moment. This is an international society. We define it as a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications alongside conventional cancer treatments. So I'll tell you what we mean by that in a minute. We aim to optimize health, quality of life, and clinical outcomes across the cancer care continuum and empower people to prevent cancer and become active participants before, during, and beyond. So I think it's important to make a distinction in some terminology that Richard was touching on in his good session on how to find good information. So we make a distinction between what we call complementary therapies and alternative therapies. So complementary therapies are different interventions, products, procedures. They may not traditionally be part of conventional medical care like surgery, chemo, radiation, but they're typically used alongside conventional treatments. So these may be natural health products, mind-body therapies, exercise, nutrition, energy therapies. But they're used with conventional care and they're evidence-based. And that's in distinction to what we would call alternative therapies, where these are things that are chosen instead of conventional care. So the clinics in Mexico that Richard mentioned, they're usually not evidence-based and they're often very expensive, require travel to other countries. They're not part of integrative oncology care. So when we talk about integrative oncology, it may be the same types of therapies, but these are the ones that are evidence-based and they're used alongside conventional care. So when we look at the categories of complementary therapies within this field of integrative oncology, there's three main categories. So lifestyle modification, and here we're talking about exercise, physical activity, eating a healthy, nutritious diet, sleeping properly, and managing stress. So we call these foundations of wellness. And then there's mind-body therapies, and that's kind of my area of specialization, where we look at things like meditation, yoga, acupuncture, Tai Chi, Qigong. There's many other mind-body therapies, relaxation, imagery, hypnosis, all those kind of things. And then there's the natural health products. So these are largely vitamins, minerals, and different herbs. And again, there is growing evidence for many treatments within each of these categories to be beneficial during oncology care. It's just quite complex. So we often talk about the mix of 6 protective factors, and I really recommend this book by a colleague of mine, Lorentz Cohen, Anti-Cancer Living, it's called. And in this book, he covers diet, physical activity, stress management, sleep, love and support, and also environmental toxins. So how you can make your environment within the house and outside safer. So I'm mostly going to talk about stress management and slightly touch on sleep in this talk. So I'm going to focus mostly on what we call mindfulness-based interventions or mindfulness. It's become a very trendy term. And I like to joke, if you look at Time magazine covers, you think that if you practice mindfulness, you turn into a blissful, beautiful, young blonde woman. So there's lots of myths out there around what it really is. It's really not that at all. Our definition of mindfulness is simply paying attention on purpose in the present moment with an open, accepting attitude. So it's kind of two things. It's a way of being in the world. You can be more or less mindful no matter what you're doing, right? It's just a matter of how much attention you're actually paying to it, whether you're washing the dishes or mowing your lawn, right? And it's also a practice, though, of mindfulness meditation that trains us in the ability or the skill of being mindful, because mindfulness is simple, but it's not always that easy. So you can look at this cartoon to kind of illustrate that, right? So you've got the human, and I always say, who's more mindful, the human or the dog? Right? And the human is not seeing what's in front of them. Their mind is cluttered with all kinds of things, but the dog is right there in the moment. So actually, maybe we should all be a bit more like our dogs sometimes. And this photo just illustrates the practice of setting aside time, sitting down, practicing mindfulness meditation. You don't have to sit cross-legged on a rock to do this, but it's just a sort of easy illustration. So if you think about your attention being in the present moment, if it's not in the present moment, what's your mind doing instead, right? So research shows we have anywhere from 50 to 70,000 thoughts every day. I mean, that's a lot of thoughts, right? So how many of those are actually in the present moment? Well, the researchers have looked at this in various ways and sort of pinged people throughout the day and said, what are you thinking about? How are you feeling? And the number that has come along is about half the time. About half the time we're not in the present moment. And often people say, oh, I thought it was more like 90% of the time I wasn't thinking about what I was doing. So about half the time our minds are wandering. And it also turns out that people report feeling happier when their attention is in the present moment, no matter what they're doing. So why would that be, perhaps? Well, if you think about where your mind is going when it's wandering, often it's to the past, right? So we may be ruminating or saying, if only this, if only that, shoulda, coulda, woulda, why me? And then you get down and depressed, you might get angry and resentful, right? And so you're having all those negative feelings, or, when you're in the past, or your mind's racing off to the future, like this guy, right? You're worrying about, what am I going to do? I've got so much to do, or what if this happens, or what if that happens? And you get all worked up and you get all stressed and anxious, right? So you're either depressed and having regrets, or you're worrying and you just miss the present moment, in which many times everything is just fine. If we can just be there and be present for it and sort of train our minds to be more in the present moment. So the focus is more on the now rather than yesterday, which we can't change, and tomorrow, which we have no idea how that's going to pan out. It's just doing our best by being awake and aware now in the present moment. So when we break mindfulness down, we talk about three different components: the why, the what, and the how. So the why is our intention. Why would we practice mindfulness? Our definition says on purpose, and there can be many purposes, but the point is that there's an intention to do it. So you may be doing it to help yourself sleep, right? Or to manage pain, or maybe you just want to be more present in your relationships with your grandkids, whatever it is. There's a kind of a motivation there. And then it's also the core of the practice is what do we do? We're training our capacity to pay attention, because you can't just be mindful because you want to, because our minds are trained otherwise. So we have to retrain them. And that's attention training. That's the formal practice of mindfulness meditation. And then there's the how do we do it, the attitudes. It's really important that we have an open, accepting, kind of kind-hearted attitude, because it's difficult and a bit frustrating at first. And if we start saying, oh, I can't do it, I suck, this is too hard, you're just going to quit, right? So we need to be patient. We need to be non-judging of our experience, just taking it as it comes. It is what it is. These things take time. It's not like a fast food sort of approach to mindfulness. We have to accept our experience. So I'm going to talk about myths in a second, but it's not always blissful and unicorns and rainbows, right? We have difficult emotions. And so we need to just accept where we are, and that's okay. And letting go of the need to control things that are outside of our control, not striving for particular outcomes, trusting ourselves, trusting the process, and approaching things with what we call beginner's mind, as if you're starting over, seeing things for the first time. And if we think, well, that's a tall order to do all these attitudes. Well, what would you be like if you were the opposite of these things, right? You'd be a judgmental, impatient, rejecting, grasping, striving, suspicious know-it-all. And that's basically a recipe for stress, right? So I mentioned myths. So mindfulness is not the same as relaxation. You won't always be relaxed when you practice awareness. It's not a form of hypnosis, or you're trying to, alter your mind state. It's not a form of prayer or a religious activity at all. It can be done very secularly and integrated with whatever religious or spiritual tradition you may already have. And it's not clearing your mind of all thoughts, like the blissful women who look like their minds are blank. No, and it's not always peaceful and calm. It's just awareness of what's happening in the moment as it's happening, with self-compassion and kindness. That's what mindfulness really is. So why mindfulness? Why is it beneficial across so many of these symptoms I talked about? Well, the only certainty in life is change. That's just a fact. But the unwilling to acknowledge and act upon that reality is actually the root cause of all suffering. It's actually the basis of many philosophical systems and awareness of this. So mindfulness is a process by which we can face and accept this inevitability of change and not be overwhelmed by it, and not fight against change, which is just a losing battle. So we use a lot of poetry in our program. I love this one from Thoreau. I went to the woods because I wished to live deliberately, to front only the essential facts of life, and see if I could not learn what it had to teach, and not, when I came to die, discover that I had not lived. Right? We can sleepwalk through our days. Years pass like that. And what happened? Were we even there for it? We were so busy planning for the next thing, we miss what's right in front of us. So this is where I usually do a little breathing exercise, but I think I will skip it because we did have a little breathing exercise just before this. But, even something as simple as the breath is often the focus of the meditation, and without changing it, just noticing it, right? Just actually paying attention to something that's constantly happening in our bodies that we often don't pay attention to. So there's a program, a real classic program called Mindfulness-Based Stress Reduction, which is training mindfulness skills, and which was developed late in the 1970s, over 40 years ago now, by a guy named Jon Kabat-Zinn in the United States. And he wrote this great book, Full Catastrophe Living, about it. It's in the zillionth edition now. I highly recommend it. And so he put together an 8-week training program. It combines stress reduction with these mindfulness meditation training techniques. And now there's been lots of research over the decades to show that this MBSR program is very effective for a wide range of physical and psychological disorders and symptoms. If you're into research, there's a great website called GoAMRA, that's American Mindfulness Research Association. It's got research summaries, all the papers you can access there. But it's become quite a sort of scientific focus for many researchers. And this graph here just shows you the growth of scientific papers. Well, hold on, there should be another line there. From just the peer-reviewed literature on mindfulness. So any articles with mindfulness in the title. And so what you're seeing here is that there was barely nothing through the 80s and 90s. And then kind of around here, the first paper we ever did on mindfulness for people living with cancer came out in the year 2000. So we were, at the beginning of the start of this whole, exponential growth in mindfulness papers. And so now we're looking at over 1,000 published every year in the scientific literature around the use of mindfulness for all sorts of different clinical conditions and, depression, anxiety, all this kind of stuff. So let's turn to mindfulness for cancer patients, survivors, and families specifically. And so the question is, why would this be helpful? I've sort of touched on this. But you see the spider, he's saying, oh, my life's a mess, Doc. You've got to help me. I just seem to be spinning out of control, right? And so people going through cancer can relate to the spider, right? It's, again, I talked about this illness experience, all these different symptoms. But it turns out that what I've just described, the mindfulness approach, is really helpful across the spectrum of these symptoms. So it teaches skills in emotion regulation. So understanding your emotions, seeing as they come up and as they sort of grow and as they fade away, and these attitudes of acceptance, non-attachment, letting go, self-compassion, all of these help us cope with these difficult emotions and experiences. So we have this program we call Mindfulness-Based Cancer Recovery. And this is just an example of a group of patients in the program. And we developed it back in 1996 with some of my colleagues and I, based on personal yoga and meditation practice. And I showed up a year or so later and I knew about MBSR. And so we adapted the program with the MBSR model in mind, but specific to some of the needs of people living with cancer. So this program has been going on clinically in Calgary since 1998. Any cancer patients and family members can sign up. We do it in groups of about, well, now 10 to 20 people. 3 times a year. We've had well over 3,000 people through the program. And so we've been doing research all those years as well. So we have the ongoing clinical program, but we embed different research studies within that. And we've done work with breast cancer, prostate cancer, you know, kind of across the board. So it's started as 8-week, now it's a 9-week program, about 2-hour weekly meetings now with 1 or 2 instructors. And every week there's a sort of a discussion around home practice, around different topics. And then we practice yoga as well, mindful movement, we call it, and different types of meditations. So we do things like body scan, sitting, walking. And there's a booklet everybody gets that includes reading lists, and we have recordings that people can use. Used to be CDs, but now it's online, where there's guided meditations throughout the program. So people keep track of how much time they're meditating. We encourage them to practice every single day. And there's a longer 6-hour silent retreat as part of the program too. So over the years, Michael and I put this program into a book that anyone can use. It's sort of a self-guided program. So it's called Mindfulness-Based Cancer Recovery. It came out first in 2011. It covers the whole curriculum and it's in a bunch of languages now. I think we've got French, Dutch, Spanish, German, a couple of versions of Chinese, and others as well. So if you're not able to join a program in person, you can do a home study with the booklet. So I briefly mentioned the types of practices. The people in the upper right that are lying there looks like they're having a nap. They're actually doing a meditation practice called a body scan. They're taking their attention throughout their body very slowly. The fellow in the chair is doing sitting meditation, so you don't have to wrap yourself up like a pretzel to do this practice. Walking slow, kind of mindful walking is one of the core practices. Something called open awareness, just open to whatever is happening in your experience. We use imagery like a mountain or a lake, and also practice loving kindness towards oneself and other people. And I mentioned yoga. So yoga is a core part of the practice. And again, just getting in touch with the physical body, you know, loosening up a little bit, but really it's more about just mindful movement, because we can kind of get detached from what's happening physically, especially if we go through different treatments. So as I said, we've been doing research for a real long time on this program, and I'm just going to summarize some of the results, but you can get them all on my website if you're keen to read the papers. I think it's, yeah, there's the publications right there. So just in a nutshell, you know, this program seems to improve symptomatology that people would be suffering from. So we started looking at stress and mood symptoms, and wow, we were actually quite shocked at how large the improvements were when we first started doing this. So it helps decrease stress symptoms, improve anger, anxiety, depression. Symptoms like sleep and fatigue improve. People do tend to ruminate and worry less. And we have done work with partners as well who show similar improvements. And then improvements in psychological well-being, like quality of life, measures of what we would call spirituality or post-traumatic growth. And these are asking questions like, you know, is there a sense of connection that you feel with something larger than yourself? Do you feel a sense of meaning and purpose and peace in your life? And overall levels of, you know, mindfulness itself, the ability to be awake and aware as you're going through your everyday life. And we've also done things like take blood samples and saliva samples and looked at what's going on inside the body in terms of blood pressure. We've looked at stress hormones like cortisol. We've looked at inflammation in different cytokines and parts of the nervous system. And so all these things have improved in different ways. We've even looked at the DNA, which is a marker of cell aging, and looked at telomere length and shown that the mindfulness practices affect that as well. So you can find all those papers on my website. But the problem has been too that not everybody can come to an in-person group. So almost all those studies were done on these in-person groups where people come, you know, for 8 weeks and they practice. But that's not for everybody. Depending where you live, you might not have accessibility. It does take quite a bit of time out of your day, and the cost of coming and parking and lost salary and childcare, et cetera. And sometimes the symptoms and side effects themselves make it hard to get to the groups if you're just too tired or in pain. Also, many people going through cancer have immunosuppression and they're told to avoid crowds. And then COVID-19 came along. And so everybody sort of switched to doing things virtually. So we've adapted this program to digital health interventions, they're called. So there's actually a couple of different versions of it. So one is an online mindfulness-based cancer recovery program where we have done some studies and partnered with a company called eMindful. And they now offer it in interactive online real-time groups. We've done a couple of studies looking at that. We're doing one during chemotherapy to see if online mindfulness might help actually prevent some of the symptoms that people get during chemo. And another thing we're working on now, I'll tell you more about in a minute, is creating a mindfulness app that people can just use on their phones or on their tablets. And again, we've partnered with an app creating company to put this together. And the latest thing that's kind of fun is that we have done some virtual reality, that's the app, some virtual reality guided mindfulness practice specifically for cancer survivors who are experiencing chronic pain. So they can put on the virtual reality headset, they'll get audio guided mindfulness, and they'll see this immersive environment of different nature scenes and stuff like that. So we're in the middle of a study on that right now. So the partnership with this emindful.com company, they have a whole variety actually of different programs that people can sign up for. So not only the mindfulness-based cancer recovery, but it might be too small to see, but they have all sorts of different specifically targeted mindfulness programs. And this is the app I mentioned. It's called the Mindfulness-Based Cancer Survivorship Journey. And it's within this larger app called AM Mindfulness or AMDTX. And so what we did was take the teaching we do in our mindfulness program, and we recorded ourselves teaching, and then they turned it into 27 different audio tracks that are listened to over the course of 4 weeks. And for each week, there's a little teaching session, and then there's these experiential things, so movement and meditation and journaling and stuff. So it kind of parallels the in-person program. Now that's a video I'm not going to show you just for the sake of time. But this is actually a good opportunity for people because we are testing out that app, the MBCS Journey, in a Canada-wide study. It's funded by the Canadian Cancer Trials Group. And so we are actually just about to start. We're recruiting 345 cancer survivors. We're actually trying to target men a little bit more because often we get more women in these programs. So we'd love to have any of you guys who are finished treatment might be interested. Recruiting soon. It's actually about to be launched any time now. And so people on the study would get access to the app on your phone for a year. You use it for a month. We ask you a bunch of questionnaires before and after. So if you're interested, you can email me directly and I can put you onto the study team for that. All right, so that's the whirlwind tour of kind of mindfulness in general, the programs, the research. And I want to be able to leave you with some practical tools that you can take with you. So I'm going to talk a little bit about the nervous system and how we can use something as simple as the breath to control our level of anxiety and excitement there. So first of all, we want to talk about the voluntary versus autonomic nervous system. So it's simple, basically. If I decide I want to raise my arm, I do that voluntarily. I say, I'm going to raise my arm, and then I raise my arm, right? But there's lots of things your nervous system controls that you don't have to think about for them to happen. So that would include beating your heart, breathing, your lungs breathing, all the different hormones that are secreted by your glands, your digestion, all those things are controlled by the autonomic or automatic part of your nervous system. And within that, it's broken down into two, what we call arms. So the big A is your autonomic nervous system. The S and the P are what we call sympathetic and parasympathetic. So it's fairly simple. The sympathetic is your fight or flight response, right? That's when, you're driving along, dog runs in front of your car, you are automatically activated very quickly. So your heart starts racing, your palms are sweaty, your muscles go tense. That's that fight or flight reactivity. That's controlled by your sympathetic nervous system. But because it's in balance with what's called the parasympathetic, the relaxation side, it's always one or the other. So if your sympathetic is activated, you're obviously not relaxed, right? And so when you're relaxed, you feel this rest phase or this relaxation response, then your fight or flight response goes down. And so what is really good throughout the day, or what we're seeking, is more balance between those arms so that we have, balance in our nervous system. So we're not too fatigued or tired, but we're not too jumpy and anxious either. And so it turns out that we can use the breath to manage that balance. So what I'm showing you here is that, and I often ask people if we do this in person, which part of the breath, the in or the out, would be associated with more the sympathetic, the fight or flight, the arousal side. And if you stop to think about it just for a moment, you might realize that, the in-breath is more energizing, right? So when you're anxious, you might have these short in-breath, like, right? You're breathing in a lot more, it's more emphasized. But then when it's time to relax, you might have a big sigh or an exhalation like, so it turns out that the exhalation fosters or supports the relaxation response, the parasympathetic side of the nervous system. And the inhalation gives you more energy and supports that fight or flight. Okay, so what? Well, we can use the in-breath and the out-breath to balance our autonomic nervous system so that we feel more calm in our everyday life. How do you do it? It's real simple. I'm going to show you a balanced mini, what we call, so a breathing exercise that balances out the nervous system. This is real simple, but the first thing we need to do is try and let our breath naturally become kind of deep and slow. So we can do that first, and then I'll show you a kind of pattern of breathing you can focus on. So, to breathe naturally and easily, we need to sit up. You don't have to be like military straight, but just enough space that your chest can expand with the breath. So sitting up a little bit, we usually put our feet flat on the floor and just bring your attention to your breath. And at first, don't even try to change it. Just notice what's happening with it here. So breathing in, breathing out. Allow your belly to soften a little bit. And so often what we need to do here is just release tension, not control the breath so much, but allow it to just become even so that as you're breathing in, it's about the same duration as you're breathing out. Okay, and then we're going to add in a little count here, a little pattern. So this is called the wave of the breath. So as you're breathing in, you can visualize the wave and count up 1, 2, 3, 4, and then straight to an out breath, 4, 3, 2, 1. So imagine tracing these nice waves in and out, or you can make a little figure eight. Some people like that, but try doing that for a few breaths without forcing the breath, just trying to make it feel pretty calm and natural, but adding in this count. And you may need to speed it up, or maybe a count of 3 is better than 4, but just, you can even close your eyes and visualize that wave coming up to 4 and then down, 4, 3, 2, 1. So softening through your belly, feeling your shoulders drop down as you go down the backside of the wave. Okay, so just opening up your eyes, and you can even note in the chat if you want how that felt, if it was easy or difficult, if it, sort of brought down your level of tension a little bit at all. And sometimes these take a bit of practice. But the nice thing about these, what we call mini breaths, is that you can do this anywhere, anytime. You don't have to close your eyes. You can do it when you're sitting at a red light. You can do it when you're waiting in line. You can do it when you're getting your blood taken even. So the next one is also balanced. We call it square breathing. And here we're going to add in a little pause. And so the same thing, we're going to breathe in, say for 4, but then at the top of the breath, when your lungs are mostly full, not bursting, you're going to pause. So just sort of hold your breath, and maybe 4 doesn't work, maybe just 2. And then as you exhale again for 4. And then when your lungs are mostly empty, we add in a little pause for a 2 or 4. If it's 2, it's like a rectangle. If it's 4, you're more like a square. So try doing that. Some people find this a little more challenging if you're not used to it, but try just adding in, even if it's very brief, a little pause with the lungs full at what we would call the top of the breath, kind of. And then exhaling in a little pause at the bottom. let's take a break from that. And just noting, I don't know if you would have noticed as you did this, if it felt different when you paused at the top with your lungs full versus pausing with your lungs empty. You know, how did you like it? How did that feel? Feel free to put a little note in the chat if you liked it, which pause you liked better, because the next ones we're going to emphasize either a relaxing aspect of the breath or a more energizing. So the next one we call the relaxing triangle breath. And here we're keeping the pause just at the bottom of the breath. Why? Why would that be relaxing? Remember at the beginning, I talked that the inhale was more energizing and the exhale was more relaxing. So here we're emphasizing 2 out of the 3 sides are emphasizing the exhalation. So it's kind of, it's not balanced like the other 2, which is like even emphasis on the in and the out. So we breathe in for 4, and then we immediately go out like the wave. But then when our lungs are mostly empty, we pause. So we're sort of emphasizing that element of the exhale that reinforces the relaxation response. So give it a try. So inhale, say for 4. Exhale down the side of the triangle. And then just pause. So there's stillness there for the pause, and then keep going. Try it a few more times. And you can adjust the length of the pause to whatever length feels comfortable for you. All right, and we'll finish you off with one more breath that is the invigorating triangle. So this is an upside down triangle where we emphasize the inhalation. So it's the same thing. We're going to have a pause just after the inhalation. So exhale and then immediately inhale and then pause. By pausing after the in-breath, you might be able to feel your heart rate accelerating a little bit. That's the physiological effect of it. And so if you're feeling, I use this one, let's say I'm driving on the highway and I'm feeling drowsy, I use this one to wake myself up a little bit. So those are just a couple of minis that you can use anytime, as I said, anywhere. And I'm just going to end by giving you a few resources and tips if you're interested and you want to start. Everyday mindfulness with just mini breathing exercises whenever you feel stressed or worried or you have a pause. And then there's all sorts of resources too. And as I said, I'll share these slides with you, but there's free apps you can get. My favorite is Insight Timer, and then the AMDTX that has our mindfulness-based cancer survivorship app within it. There's many free websites, so these resources don't have to cost you anything. And some of them will have entire MBSR programs that I talked about at the beginning that you can take for free online, and really good guided meditations and resources. So feel free to check some of those out. I mentioned the Society for Integrative Oncology. Our mission is to advance evidence-based comprehensive integrative healthcare to improve the lives of people affected by cancer. We have an annual conference every year. We have many patient advocates involved who come to that. Our 2022 one is coming up in Arizona in October. And then I'm really happy to say that we are hosting the 2023 conference in Banff. And it's our 20th anniversary as well. So check us out. We'd love to have more professionals and also more patient advocates and survivors and family members as well. So finally, to summarize, mindfulness is present moment, non-judgmental awareness with acceptance. It's a way of being in the world cultivated through meditation practice. And programs like mindfulness-based stress reduction, mindfulness-based cancer recovery train people in mindfulness and help decrease a range of symptoms like anxiety, stress, and depression. And this mindful awareness can help people cope with everyday stressors. So I'm going to end leaving you a bunch of contact information. I mentioned my website with all sorts of scientific papers. Feel free to email me, follow me on Twitter. There's a Facebook page called Mindfulness-Based Cancer Recovery. And there's a whole website, Mindful Cancer Recovery, that's got lots of different resources as well. And there are some free guided meditations that we use in some of our work at this website as well. So I will leave it at that. Thank you very much.
Thanks, Dr. Carlson. That's great information for all of us, whether we're living with prostate cancer or any kind of cancer or not. So thank you very much. We're going to go on to the next speaker as Reanne Booker. We're going to be talking about maintaining intimacy and partnerships affected by prostate cancer, which is a challenge for all of us who are dealing with prostate cancer. Reanne is an oncology and palliative care nurse practitioner with over 20 years experience in nursing and a PhD candidate, researching the integration of supportive and palliative care for blood cancer patients and their family caregivers. She works with the palliative and end-of-life care services program in Calgary and also serves as president of the Canadian Association of Nurses in Oncology. Welcome, Reanne.
Thank you so much, Marie. And thank you all for the invite to be here. And thanks, it's great to see so many people here this morning. So I'm just going to try and share my slides here. And if, Rochelle, can you just give me a thumbs up if you can see those? Good. Awesome. Okay, thank you so much. And as Marie said, I'm the president of the Canadian Association of Nurses in Oncology. And for a number of years, I actually ran a sexual health clinic at the Tom Baker Cancer Center in Calgary. I've been involved in sexual health and cancer care since 2005. So for a few years anyhow. So these are my disclosures. I haven't received any funding at all or have any financial relationships with industry or medical supply companies, but I have received some funding from nonprofit organizations for my PhD studies and research. So today, of course, the information I'm sharing is for educational purposes only. It's not a substitute for medical advice. And before you make any changes to your treatment plan or if you have questions more specifically about treatment for medical conditions, talk to your doctor or healthcare team. So I want to talk today about the potential impact of prostate cancer and its treatment on sexuality and intimacy, and then talk about some strategies to help optimize sexual health and intimacy after a prostate cancer diagnosis. So this is a bit of a busy slide with lots of words, but I just want to draw your attention to the bolded section. Sexuality is an aspect of being human throughout life. I also want to emphasize that sexuality is not the same as sexual function. Sexual function is a part of sexuality for sure, but it's not the only part, nor is it the defining part. So there's a quote from a paper I read a few years ago that if sex is something we do, sexuality is something that we are. And when I first started looking into and working with people with cancer who had concerns about sexuality and sexual function, I realized it's really quite complex. So sexuality, as I said, is a very broad concept that encompasses aspects of self-image, body image, patterns of affection, social, family, gender roles, and physical and emotional intimacy as well. Factors that influence sexuality may precede a cancer diagnosis. They might arise upon being diagnosed or treated for cancer. And some of these factors, of course, are associated with normal aging. And then other factors are exclusively related to the cancer or its treatment. It's kind of tough to tease out which is which, though. It's very complicated. Sexual function relies on nervous, vascular, or so blood flow, and endocrine system function. And of course, we know that the brain is a very important component and very important sex organ. And then we also know that there's an array of psychological factors that can contribute to altered sexual function and sexuality. So body image, self-esteem, altered mood, depression, anxiety, gender role confusion, and fear. And again, many of these can be influenced by cancer and its treatment. So if you think about sexuality across the illness trajectory, there can be different concerns that patients may have. So the time of diagnosis, of course, people are rightly concerned with survival and treatment, what it will take to control or cure the cancer. And the focus very much is on getting better. But at the same time, there can be some really important concerns that should be discussed. And we know from research and also from experience that healthcare providers are notoriously bad for not talking about sexuality and concerns. So they'll often wait for patients to bring this up, and patients often will wait for the healthcare provider to bring it up. And as such, it's often ignored or under-addressed. At time of diagnosis, though, it's really important. So fertility is a concern. This is the time to have those discussions. And then during treatment, again, it may not be forefront for everyone. But, you know, it's important to think about things like side effects, low counts and things like that in terms of safety of some types of sexual activity. Some people very much desire that physical closeness and even sexual activity during treatment. So it's important to have discussions about ways to protect both the partner and the patient. And then recovery and survivorship. So this is where we saw most of the patients come to us in our sexual health clinic, is once treatment was finished and they were trying to figure out how to return to sexual function and sexual activity. Very often they'd be referred to our clinic at that point. And then again, a lot of people don't think about sexuality or sexual function during advanced disease or even at end of life. But a lot of patients that I've seen it over the years talk about really wanting to maintain some form of intimacy, especially at end of life. So again, it may not be sexual intercourse specifically, but that desire for physical and emotional intimacy is something that we very much wish to continue even in the context of advanced disease and at end of life. So this slide, again, very busy, but just to make the point that it's very complicated. So there certainly are some things that cancer treatment can do regarding sexual function. We know that there can be lots of changes in terms of sexual function, and then significant impact on psychosocial well-being as well. I know earlier today, we've heard a number of great presentations. I know that Nicole this morning went over a lot of this already, so I won't belabor this. And then a great presentation by one of the Phils about active surveillance and watchful waiting. But just to make the point here that there are a variety of different treatments that can be offered for prostate cancer. And all of these come with varying degrees of the potential impact on sexual function. So the surgery itself, so we're thinking about things like radical prostatectomy, and that can be either open or robot assisted or laparoscopic. We know that with the removal of the prostate and the seminal vesicles, there can be significant changes in sexual function. So after prostatectomy, we'll see reduction in the fluid that comes with ejaculation. So accompanying that as well, there's no fluid buildup in the urethra. So that sense of fullness or inevitability really abates. So that can be a big change. And then that absence of ejaculate or dry orgasm, where there's no semen coming out, can be a big change as well. There can be penile shortening, erectile function challenges. And we know that this can happen because there's damage to the nerves and blood vessels that can happen during prostatectomy. We know with nerve-sparing surgery, the risk of erectile dysfunction is reduced, but it's not absent. So after nerve-sparing surgery, there still can be risks of erectile function changes in the neighborhood of 40 to 50%. That can improve a bit further out from treatment. So 1 to 2 years post prostatectomy, there may be some return to function, but still pretty significant risks. Orchiectomy is another surgical procedure. So that's removal of the testicle. And again, that's to reduce the amount of testosterone. And with that, of course, we can see changes in desire, erectile function, and then transurethral resection of the prostate, or TURP, that can be done for benign prostate issues. So benign prostatic hypertrophy, enlargement of the prostate. Or sometimes in the cases of very advanced prostate cancer, where the intent is not necessarily to cure the underlying cancer, but to help relieve symptoms, a TURP may be done. And what can happen after a TURP is not as common to have erectile function issues. They still can be present for sure, but there can be issues with something called retrograde ejaculation. And I'll speak about that a little bit more going forward. And pardon me, that's just a diagram there of a transurethral prostatectomy, and then, or resection of the prostate, sorry. And then this diagram here on the right is just showing all the different nerves that can be damaged during both surgery and radiation treatment, actually. So again, radiation for prostate cancer, we know that there can be significant challenges with erectile function post-radiation, and sometimes those challenges will actually increase for up to 2 years post-RT. The rates after brachytherapy of erectile dysfunction are a little bit less than external beam radiation, but still in the neighborhood of 25 to 50%. There can be decreased volume or absence of semen, discomfort during ejaculation. So there can be irritation of both the urethra and or the epididymis that can cause discomfort during ejaculation. That tends to subside the further somebody gets out from radiation. Decreased desire or interest in sexual activity, decreased intensity of orgasm, and then overall decreased satisfaction with sex can all happen. And the reason for the changes, we suspect, and research has shown, that it's likely vascular. So we know that there's damage to the arteries after radiation therapy, and also damage to the nerves. And so those can be problematic for sure. We have newer techniques. So intensity modulated RT, that enables adequate dose delivery with improved sparing of normal tissue. Hypofractionated, and we saw this quite a bit during COVID, where we weren't bringing people to the hospital as often for treatment. So we had higher doses per fraction of radiation. And then things like stereotactic body radiation. So some of these newer techniques, it's been hypothesized they might lead to reduced side effects. At least that's part of the intent. But so far, we haven't seen significantly compelling evidence to say that any of these techniques, the newer techniques, are better necessarily. So right now, the only thing we know for sure is that brachytherapy is associated with reduced erectile function changes for some men. But hopefully the newer techniques, as they refine them and get better at them, we'll see reduced side effects as well. So hormone therapy for prostate cancer. So we're looking at either reduced androgen production by the testes that can be done medically or surgically, looking at blocking the action of androgens in the body, or blocking the production of androgens throughout the body. And the diagram here on the right, or the figure, shows testosterone production and how it's regulated in the body. But we know that people who have hormone therapy, or I guess it's more aptly called anti-hormone therapy, is definitely associated with sexual side effects. So we can see reduced desire and interest in sex, significant challenges with erection. So in the neighborhood of 90% of people being treated with androgen deprivation therapy can experience erectile challenges. There can be hot flashes, weight gain, gynecomastia, so enlargement of the breast tissue, and decreased penile length and testicular size as well. And so looking at the sexual response cycle, historically, we had what was almost a bit of a linear process, where we had, this thought that there was desire, and that was followed by arousal and excitement, plateau phase, and then orgasm. But what we know now is it's quite a bit more complicated. And this is work that's been done by Rosemary Basson in Vancouver, looking at, this notion that we don't need spontaneous desire to happen first in order to have a satisfying sexual encounter. So that, spontaneous desire, or that feeling of being good to go at any point, need not be there in order for someone to have a satisfying sexual experience. So that spontaneous desire can be absent, and you can get into, a situation where there's some touch and cuddling and things like that. And then arousal can even happen first, and then desire might happen after arousal. So it's not this kind of linear step-by-step process that was once touted as being what the sexual response was for humans. Definitely changes in erectile function. Again, we heard this from Nicole this morning. There can be difficulty achieving erections, difficulty maintaining erections, insufficient firmness for penetrative intercourse, and that could be vaginal or anal. And for anal intercourse, you need to have about a 30% firmer erection compared to vaginal intercourse. There can be loss of spontaneous erections, loss of those early morning erections as well. And we know that changes in erectile function happen with normal aging. So more than 50% of men who are older than 40 without having any cancer have some degree of erectile challenges. There's a number of different medical conditions and medications that can also influence erectile function. So anything that impacts nerve function, blood flow, hormone function, all of those conditions and medications can all impact erectile function. So things like diabetes, high blood pressure, cardiovascular and coronary artery disease, all of these things and their medications can contribute. And so certainly nerve damage, blood vessel damage, changes in hormones, and then of course, psychological functioning and distress can also all play a role. And in many cases, it's a combination of all of the above. The good news is that not all, that erections are not needed for orgasm. So you can still have ejaculation and an orgasm, even in the absence of having an erection. And then in terms of the ejaculatory changes, there can be delayed or premature ejaculation. So it may take longer to achieve ejaculation, and that could be due to the altered hormone environment, neuropathy or nerve damage. If there's discomfort or pain, or even, again, that psychological distress component, those can all play a role. Pain with ejaculation or dysejaculation, again, doesn't happen all that often, but can happen after radiation for sure, where there's that irritation of the urethra or the epididymis. And that, again, tends to subside over time the further one gets out from radiation. There can be, as we know, anejaculation, so little or no ejaculate, and retrograde ejaculation, where the ejaculate actually goes into the bladder rather than coming out the urethra. And that, again, is due to damage that can happen to the sphincter at the bladder, particularly after a transurethral resection of the prostate. And again, there can be urine leakage at the time of ejaculation or climacturia. In our clinic, we did see some people having changes in ejaculation. More often than not, we saw erectile challenges and then changes in orgasm. So, the research shows that about a third of men will have orgasms that are less intense. Some will actually have orgasms that are more intense. So about a third, and then another third will have orgasms that are more intense. There can, again, be painful orgasms. So again, at the time of ejaculation and orgasm, that can be painful for some. And then there can be complete loss of orgasm or anorgasmia. Fertility could be an entirely separate talk, so I won't get into this too much, but just to say that the treatments that we offer for prostate cancer, they may temporarily or permanently impact fertility. So ideally, these discussions about fertility preservation should happen early before treatment starts. And, for some types of cancer, in most cases for prostate cancer, there is a window of time that you could pursue fertility preservation strategies. But for some types of cancers, it's not possible. And again, for many men, their desire is to just get treatment started immediately rather than having any kind of delay. Right now, the main method for fertility preservation for men is freezing or sperm banking, freezing sperm or banking sperm. There's other methods as well, but they're under investigation and considered more experimental. So you can freeze testicular tissue and things like that. But right now, freezing semen is the method that most men will pursue. So there is some cost associated with that as well. It's approximately $400 for the first year of storage, and then about $200 per year thereafter. And there are a couple of different organizations. There's one in Canada called Generations of Hope that will offer some financial support for fertility preservation. Body image is huge. And so, there's a lot of different things during cancer treatment that can impact body image. We know that penile shortening and testicular shrinkage can be significant with a variety of the different treatment modalities. Gynecomastia or enlargement of the breast tissue can also happen. Weight gain and weight loss are both very common depending on the type of treatment and what else is going on. And Dr. Wassersug, I'm not sure if he's still connected with us, but he spoke earlier and he's done quite a bit of work in this area about, what does it mean to be masculine and how is masculinity impacted by cancer treatment, particularly in the context of prostate cancer. So I would invite you to look up his work because he's done some tremendous work in this area for sure. And relationship changes. I think that this can be challenging for people irrespective of their situation. So if they're single and getting into the dating world and having to disclose a history of cancer, that can be very challenging. But it can also be challenging for people that are in a long-standing relationship. So for many of the patients we see, or we had seen in our sexual health clinic, sexual function and sexual activity and that intimacy had been pretty stable for a good chunk of their relationship. And then cancer kind of threw this rude awakening into things, and communication was really key. But a lot of the patients and partners that we had seen didn't have a lot of experience communicating and weren't really aware of the impact of cancer and its treatment on their sexual function. So it was really hard to have those conversations. So I think this can be challenging for people, dating or in a long standing relationship. There's really, no easier path, I would say. I think that the key here is really being able to have that open communication, and sometimes people need help with that. So again, the online dating world, and particularly during COVID, you know, this was when people were encouraged not to meet in person and things like that. I think there was an increase in some of these dating apps. And online dating comes with its own share of challenges for sure. It's not the easiest necessarily, but you know, it can be a good way for people to meet. And there is one particular dating app that is for people who've had a history of cancer. And, you know, some people might appreciate that someone else has an understanding of what it means to be diagnosed with and treated for cancer. You know, you just have to figure out what works for you and what's best for you. So again, partners, and I appreciated earlier that Glenda had mentioned that, you know, prostate cancer it impacts both the patient and the partner very much. We don't have a lot of research on the impact of cancer treatment on partners. We focus very often on the patient, as we need to do for sure. But certainly we know that the partners can be impacted in a huge way. So partners might feel fearful of causing pain or discomfort during sexual activity. So they may not want to initiate sexual activity. They may shy away from it. They might feel unwanted or unattractive or even rejected due to the decreased sexual activity. I remember seeing a couple, and the woman was being treated for breast cancer and had so many side effects from her treatment. She just wasn't interested in sexual activity at all. And her partner really felt that she was possibly cheating on him. He felt very rejected. They hadn't been communicating about it. And when I mentioned that there can be significant sexual side effects from the particular type of breast cancer treatment she was receiving, you could just see his whole face relax. And this huge awareness came over him that he had no idea that that was even a possibility. Then again, that shift in being a partner to being a caregiver can be a huge challenge for some couples as well. And then in the context of advanced disease, if there's worry about the potential loss of a partner, some people may withdraw and you know, pull back as a way to preserve or protect themselves. So that can be very challenging for sure. And then we also know that partners can have their own share of sexual health changes. So again, cancer is often diagnosed or can often be diagnosed in later in life. And so in the context of prostate cancer, female partners may be dealing with their own menopause-related sexual health changes or vaginal health changes. And so this was also part of what we did in our clinic, is we talked to the couple together. We definitely wanted to assess if there was discordance in terms of their sexual interest and sexual function, because, you know, we did see the situation where we would potentially really help somebody with their sexual function, but then the partner had his or her own changes. And if we didn't address those issues, then we created a whole new can of worms. So, you know, keeping in mind that partners may also have their own share of sexual health changes and challenges too. Sexual and gender minorities, I think this is really important. Approximately 10% or so of the population identifies as LGBTQ. We know that this population has lower rates of early detection and screening, and we don't have a lot of resources tailored specifically to LGBTQ needs. So if we think about equity in healthcare, and I won't say equality, because if you think about it, if we say that we want to treat all patients the same, that doesn't always make sense, because each patient has their own unique needs and challenges. So if you think of, for example, perhaps a patient who is blind or can't see well, if we say, well, we're going to give you the same patient handouts that we give everyone else, well, that's not really being equitable. Even though we're treating them equally, that's not equitable treatment. So we really want to strive to provide care that's tailored to the individual needs of each patient. In terms of challenges for men who have sex with men, you know, a lot of the sexual health challenges will be the same after prostate cancer for heterosexual men as they are for men who have sex with men. But there can be some unique challenges as well. So, and this can be a challenge, this first one for heterosexual as well as men who have sex with men. The prostate can be seen as and can be experienced as a site of sexual pleasure. And so if the prostate's removed, or if it's irritated or affected because of radiation or other treatment, then that might remove a potential site of pleasure. The loss of ejaculate and that inability to participate in semen exchange can be very important for some men. The lack of visible ejaculate can be a big deal as well. Rectal irritation or pain from radiation, for example, can lead to very painful receptive anal sex. There can be inadequate penile rigidity for insertive anal sex. So again, that erection needs to be about 30% more firm than is required for vaginal sex. There can be change in roles. So some men who have sex with men prefer to be what's called a top, some prefer to be what's called a bottom. So either insertive or receptive, and they may have to shift roles. Again, the absence of erection can be challenging. Change in penile size can be very challenging as well and may result in the changing of sexual roles. And pardon me, we know that a lot of our patient education materials about sexual health are very heterosexist. So they focus on heterosexual concerns in terms of sexual function changes. And the research to date on things like penile rehab strategies have really focused on penis and vagina sex. So again, very heterosexist, and we definitely need more research for men who have sex with men. And prostate cancer in transgender women. So transgender women typically will retain their prostate. So even if they have gender reaffirming surgery, they'll still retain the prostate. And we know that if they receive feminizing hormone therapy like estrogen and things like that, that means that their PSA is no longer a reliable indicator for prostate pathology. So looking solely at the PSA won't necessarily be helpful. We think that the risk of prostate cancer is probably quite low because again, there's that absence of testosterone, but it's probably not zero. And you can imagine it can be very difficult if it's a transgender woman who's identifying as a woman, then to have to be reminded that they need screening for prostate cancer, that's a male-associated cancer, and that it can be very challenging for them to have to deal with that particular aspect of their health. And then considerations when unwell or in hospital, or even in the cases of advanced disease or even at end of life. So you can imagine any of these symptoms can make it difficult to want to engage in sexual activity. And the hospital environment itself is particularly uninviting. You know, I still think to this day, and even in the context of hospice and places like that, we have single beds in hospital. And again, it wouldn't necessarily be that people want to engage in sexual intercourse, but wouldn't it be nice to be able to cuddle with your spouse or your partner, particularly if you're not feeling well or in the context, again, of advanced disease or at end of life. A few years ago, I was asked to do a talk at Foothills Country Hospice in Okotoks because the staff had walked in on a couple that was in the hospice and they didn't know what to do. They were surprised that there would be interest in sexual activity as this patient was, you know, very close to passing away. And they wondered what they should do. Should they have, you know, a sign that goes on the door or put a sock on the door or something like that? Because as you know, in healthcare, we're not great at respecting privacy. You know, we as healthcare providers will often knock on the door and walk in simultaneously. So, you know, this notion of how can we create an optimal environment for people to preserve physical intimacy, even if it isn't sexual activity specifically. So when we talk about interventions, and again, in our clinic, we were very fortunate. We had a psychologist that was part of our clinic, myself as the medical director of the clinic. Every now and then we had a gynae oncologist that would rotate through, but we took a very biopsychosocial approach because we knew that the reasons why people were experiencing changes in their sexual function and their intimacy, they were not just solely physical, they were not solely psychological. It was this intermix or combination of all the above. And so, you know, very often the psychology and the counseling piece was really important, especially around communication techniques. We really wanted to provide a lot of support for the partner. We talked a lot about non-invasive assisted devices, and I'll get into those in a minute. Managing, again, cancer and treatment-related symptoms, so pain, nausea, shortness of breath, neuropathic pain, and things like that. Penile rehabilitation, again, there's some controversy around this, that the research so far has been a bit equivocal, not showing super compelling results in terms of, really strong recommendations for robust penile rehabilitation that would be, embarking on various treatments and things, even pre-operatively and then early post-operatively. The research so far hasn't shown dramatic results in terms of improvement, but there are some strategies I'll get into in a second here. Pelvic floor physiotherapist, we had some great physios that we would refer people to, and they really do need to be experts in pelvic floor physiotherapy. And then referrals as needed. So sometimes we would refer people to urologists or endocrinologists, and definitely psychologists were a big part of that. So the communication piece, again, is really important. So sharing with the partner what is going on and the changes emotionally and physically, being empathetic towards one another and trying to be concerned about, genuinely concerned about how the other one is feeling. Planning ahead is really key. So if there needs to be pain medications taken ahead of time, or the PDE5 inhibitors is really important. Testosterone peaks in the morning, and people are often less tired in the morning. So sometimes morning sex or sexual activity can be a good idea. And then just being really patient with one another. Dr. Lauren Walker and Dr. Wassersug again, and Dr. John Robinson came up with some different questions that can help couples communication about sexual activity. So, talking about, is it okay to, look at using different treatments for erectile function, or bringing in some sex toys and things like that. What kinds of activities feel good? What doesn't feel good? Is there something that's painful now after surgery or radiation? So having these kinds of discussions can be very helpful. Again, improving intimacy and recognizing that intimacy is not just sexual intercourse or physical sexual activity. It can be emotional, sensual, sexual as well. I think this is always so funny. These two are in different bathtubs, and if they were in the same bathtub, that might actually help to improve their intimacy. That's actually from an ad for Cialis, which is kind of funny. But thinking about different ways to improve intimacy. And, very often in our clinic, we would tell people, take sexual activity off the table, not literally, but take sexual activity off the table. Because, there's a lot of pressure to put on yourself and your partner, especially early post-operatively or post-treatment. And so, don't let it be the be all end all. We would talk about other ways to maintain sensual and physically sexual intimacy. So there's things like Venus, very erotic, non-insertive sex, outer course or other course, and touching and different things like that. And then sensate focus would be a more specific special exercise that psychologists are often trained to do. And even some nurses are trained to provide sensate focus exercises. And that again is a multi-week process where you take sexual activity right off the table to start with, and just work on communication about what feels good. And for the first couple of weeks, it's not even touching the genitals or erotic areas. It's just touching each other's bodies, talking about what feels good and what doesn't. And then eventually it progresses to more intimate touching. Improving desire. So again, that idea that you don't need to necessarily be good to go or have that spontaneous desire, but that you might get into a sexual or physical encounter, and that you might become more responsive, and that desire might come afterwards. So it doesn't always have to be there. You don't have to always be in the mood, so to speak. Counseling, I always am a huge proponent of that. We just heard from Dr. Carlson about mindfulness-based meditation. So again, really being in the moment, really trying to focus on the sensations and feelings, try not to make the grocery list in your mind or think about what's coming up tomorrow or different things like that, but really being in the moment can really help. And again, this is an area that's under intense research and scrutiny right now, but possibly considering a trial of intermittent androgen deprivation therapy versus continuous. So taking, a holiday or a break from the androgen deprivation therapy. And there's some suggestion that this is not associated with worse outcomes. But again, it's very specific to each individual patient and their circumstances. So it wouldn't be something that would be for everyone. But for some men, this may be an option. And so far, the research is showing that this does not lead to worse or inferior outcomes. Improving erectile function, there's lots of different things we can do here. So we always try to figure out what is the cause or causes of the erectile challenges. And there, again, an array of different things. So the medication is probably the most well-studied. Strap-ons or external penile prostheses. The elator is a device that is seen in this picture here. It's custom made to the length and the girth of the individual patient. It comes from the States. It's about $350 US. I've heard mixed results from this, not always super helpful. Things like constriction rings, I'll get into that in a second here, vacuum erection devices, injections and implants, we'll talk about those as well. So the medications, again, we heard from Nicole this morning. These medications all work the same. So they increase an enzyme in the smooth muscle cells of the penis that leads to relaxation and increased blood flow in the corpus cavernosum in the penis. So that tube in there that will fill with blood and lead to that erection. In Canada, we've got sildenafil, Viagra, vardenafil, Levitra, and tadalafil, Cialis. We don't yet have Avanafil. The benefit of that one is that it's got a very short half-life. So typically we tell people they should not take something like nitroglycerin after they've taken these medications because it can cause profound low blood pressure. But Avanafil, because it's got such a short half-life, it's out of your system fairly quickly. So there is no contraindication to taking nitrates. But as I said, we don't have that yet in Canada. These medications are best taken in advance, so 30 to 60 minutes before sexual activity. You still need that physical touch in order to release nitric oxide and lead to the different pathways that cause erection. So you don't just pop the medication and automatically in the upright position, but they do need that physical touch. Tadalafil you can take daily. It's a lower dose. So the normal as needed dose would be between 10 and 20 milligrams. The daily dose is 5 milligrams. Some men that I've seen prefer this because they take it every day with their other medications, and that allows a steady state of that medication to be in their system. So that means there's a little bit more opportunity for spontaneity. You don't have to be as planning in advance and things like that. So it allows for, again, more spontaneity. The side effects are all pretty similar for these medications. So some people will get facial flushing, some get headache. There can be nasal stuffiness, but they tend to be fairly mild and self-limiting. The big difference between the medications, I would say, is tadalafil's got a longer half-life. And so it's called the weekender. So if you took it on a Friday, there would be that window of opportunity through the weekend where that medication would still be in your system. By contrast, sildenafil and vardenafil, their half-life is a little bit shorter. So you're looking at 4 to 6 hours for optimal efficacy. And so again, Nicole spoke about this morning as well. So in our clinic, I did teach many men how to do the self-injection. So the injections, and again, not first line therapy. So typically we would have somebody try the medications first, but we know that the injections could be very helpful if there's no nerve damage, because the injections and they're injected the medication, and usually it's a prostaglandin or some kind of vasoactive medication. We use a combination called Trimix as well, and that bypasses the need for the neural input of nitric oxide. So we know even after spinal cord injury, the injections can also help some men. So again, typically a lot of men did not like to try this as first option. They would try medications or other things first. And if they didn't work, then we would move on to trying injections. And they can be helpful for up to 85 to 90% of men, especially those with the neurogenic or nerve-related erectile challenges. The needles are small, so I don't know if you can see this. This is almost like the kind of needle we'd use for diabetes. The point of it, very, very tiny, very fine. And again, a lot of men did not like the idea of injecting something into their penis, but most men that I taught to do this found that it was not painful at all. And it really did lead to good quality erections for many. And then transurethral therapy. So the medicated urethral system for erection, or MUSE. And that again is where a substance, it's alprostadil suppository, is placed into the urethra, and then that medication is absorbed into the corpus cavernosa, the corpus spongiosum. And that can work about 20 to 40% of the time. The vacuum erection devices can also be quite effective, but you really do need a good quality device. And I know Glenda's book that she's written about prostate cancer and what a woman needs to know, she talks about a trial of one that wasn't quite as good. And then when they went on to try a better quality device, they had better results. So you really do need to get a good quality device here. And how they work is they pull blood into the penis, and then you would use something like a constriction ring at the base of the penis to trap that blood and keep that blood in the penis. And then the inflatable or the penile implants. So there's really 3 different kinds. So there's a 2 or 3 piece design for the inflatable implant, where there's a fluid-filled reservoir that's either placed in the abdomen or in the scrotum, and you can pump that up. The fluid or the cylinder will fill with saline, and that can lead to an erection. Or the other type is where there's a semi-malleable rod that's implanted. And so you can imagine then there's a semi-malleable rod, and you can use that to bend the penis into the desired angle for sexual activity. And when the sexual activity is over, then you can bring it back down. And so those are very effective penile implants, 95 to 100% effective, but that's a surgery. So again, would not be considered first line because there can be risks associated with surgery as well. Ejaculatory changes. So again, the lack of ejaculation, I think, is really important to have education and awareness, discussion with the partner. And again, as healthcare providers, we need to let people know up front that this can happen, so it's not a surprise. And then climacturia, so that release of urine at time of ejaculation. There's a few things you can do, avoiding caffeine, alcohol, and things like that. Again, using a constriction ring at the base of the penis can help. Using a condom during sexual activity can then keep the urine in the condom. Pelvic floor physio can also help. So not a lot of studies on this, but a few that have been done that do show some improvement. And very few studies looking at how to improve orgasmic function after prostate cancer. So again, the orgasm is such a multifactorial process with nerve, blood flow, hormone, and psychogenic influences. So it's really tricky to manage. But again, the counseling and mindfulness-based strategies can help. Penile vibratory stimulation, and some medications, but again, I have this one kind of shaded because they haven't been all that well studied. Testosterone replacement after prostate cancer seems a bit counterintuitive, but the theory around this is that historically we used to think this was a linear process where even a little bit of testosterone might lead to risk of recurrent disease. Now it seems that it's more an issue about receptor saturation. So it seems like there is an ability, a limit to the ability of androgens to stimulate prostate. So at some point, even if you give more testosterone, that might not lead to increased risk of recurrence or progression of prostate cancer. The tricky part is here, we don't know for sure which patients this will be safe for, what's the optimal dose, the optimal duration. I will say that this is being widely studied. So hopefully we'll have more information in the years ahead. Penile vibratory stimulation, this is the Vibrect device. There was a clinical trial that was stopped early because they had recruitment issues. But the theory here would be that vibratory stimulation might help with nerve function and might help improve erectile function. And there have been some studies done mostly in men with spinal cord injuries where this device can actually lead to orgasm and ejaculation. So stimulating the branches of the pudendal nerves that lie along the penile shaft, and then that causes parasympathetic erection through the activation of nerve terminal endings that release nitric oxide and then cause that smooth muscle dilation and erection. So one particular study, this study, did find that there was some improvements. It was not statistically significant in terms of improved erections, but perhaps more research, and we'll see if this can actually help improve erectile function. So again, stimulating, leading to more blood flow. The thought is that perhaps that might help improve the health of the penile tissues as well. This particular device costs around $430. You could achieve the same thing with a vibrator. So there's all kinds of different vibrators on the market. This one would serve almost as a constriction ring as well. That would go around the penis, the base of the penis, and can vibrate. And then there's one that can be used with a flaccid or semi-flaccid penis even, and this is called the Guyberator, It's hard to see here, but the penis would go in here and, you turn it on and the vibrations can happen. So again, that might result in orgasm or even ejaculation because you don't need the erection, might result in pleasurable sensations and might help improve penile oxygenation just because there's improved blood flow and stimulation. Safer sex, again, this is for someone, even in the absence of a cancer diagnosis, we want to make sure people are practicing safe sex with a partner whose background is unknown, or if there are any concerns about sexually transmitted infections. We don't know for sure in terms of partner exposure to chemo. It's a theoretical risk. It's probably a very small risk. Most chemotherapy drugs are out of one's system within a few days of receiving the medication. And even if there was a small amount of chemo that was released in semen, or even vaginal secretions for that matter, the partner exposure, the risk there is probably very low. But most cancer centers recommend patients wait for about 72 hours after they receive chemotherapy before having sexual activity, or use a condom or a dental dam for sexual activity. I'm almost done, I promise here. So preserving intimacy, again, it doesn't need to be physical intimacy or sexual activity. The emotional intimacy piece and relational intimacy piece is very important as well. So communication, counseling, and psychology can really help here. And then there's all kinds of different things that are erection independent. So you don't need an erection for all of these different types of physical, intimate activities. And then the erection dependent, of course, we have the medications, the injections, the vacuum erection device, and the implants. So again, it's common for changes in sexuality to happen after a diagnosis of prostate cancer for the patient and the partner. That's really key that we address both. And it really, what matters most here is how the changes affect the person and their partner. So if these changes happen and the patient and partner don't care, not a big deal. But if they do care, and if there's something we can do to help improve things, then we certainly want to do that. Lots of different interventions that can help to improve sexual function. None of them are 100% effective. Again, it's hard to let go of assumptions and expectations, but if you can, that can relieve some of the pressure on you and your partner. There's no such thing as the right amount of desire, no perfect relationship, and no such thing as a normal sex life. Again, healthcare providers can provide some assistance here. Some cancer centers now do have sexual health clinics. Not all of them do, but some do. And because of COVID, of course, a lot of these things are now being offered virtually or online. Again, don't be discouraged if something isn't working. It may be that we need to increase or change dosing of the meds, or we might have to try something different, and keep the communication going. Try to, be patient with yourself and your partner. This is a change, it's a loss, acknowledge it as such, but really be supportive to each other and, keep talking. Again, lots of different websites. It's best to go to the direct website. Don't type sex into a Google search because you can end up with some very interesting things that come up. And then again, lots of great books. We heard from Glenda earlier. This is the book that she had written after her husband, Rick, was diagnosed with prostate cancer. But there are a lot of great books as well and resources that are out there, some specific to LGBTQ. And I will stop there. Maybe I'll go back to the very, very beginning. I'll ask you to please reach out. We don't have time for questions, I don't think right now, but please reach out to me and feel free to email. If you have any questions, I'm happy to answer questions via email. Thanks very much.
Thanks, Reanne. That was great information on a topic that we rarely talk about when we're first diagnosed, but always seems to come into the fore later on.
Yes, thank you.
So we're going to move on, folks. We're going to talk about genetics and how it plays a role in prostate cancer, but how much? Here to give us all the details is Justin Lorentz, a genetic counselor. Justin practices clinically out of the Sunnybrook Cadet Cancer Center in Toronto in their cancer genetics and high risk program. He's also the lead of the Male Oncology Research and Education MORE program, a registry for men with hereditary cancer. Welcome, Justin.
Thank you so much for that. It's a pleasure to be able to speak today. I think I have 10 minutes and I have a lot to say, so I'm going to go right into it. First of all, can you hear me okay?
We can hear you.
Great. Okay. So I'm a genetic counselor at Sunnybrook. So I want to talk a little bit about prostate cancer genes, some of the known genes that are associated and what we can do differently for people's care if we know about these genes.
Hey, Justin, sorry to interrupt you. We can see your presenter view.
You can see my presenter view.
Yeah. Also, you have closer to 20 minutes, so no need to rush.
Oh, good. Okay.
Yeah.
Okay, let me just see if I can
just go back to full screen and go to swap presenter view in the upper left-hand corner, Justin.
Oh, that's a big
okay, it's easy.
Full screen.
I promise. I do it every day. Display settings, upper left.
Upper left display settings.
There you go. Swap.
Nice. Oh, brilliant. Okay.
Thanks, Dr. Cox.
Is it still in? Yeah, you're seeing all the right stuff. Okay, great. Okay, so humans are made up of billions and billions of cells. All of our cells, create our tissues, and in each of our cells we have our genes. And so this image here shows these two kind of caricature helices. Genes are very long pieces of DNA. They have instructions. They tell our body how to grow, how to function. We have two copies of every gene. One copy we inherit from mom, and the other copy we inherit from dad. And so we have these two copies that are holding hands here. Sometimes every person in their 20,000 genes that make people, we have about 5 mutations that are causing some kind of a medical problem. And that's denoted here as being this kind of red area in the gene. If there is a gene mutation that's causing a medical problem, sometimes it can manifest as a health condition. Sometimes people will just be what are called a carrier of something, and it doesn't necessarily have a direct impact. For the purposes of this discussion, gene mutations do increase risk for certain cancers because I'm focusing on genes that protect us from cancer. And if there's a mistake or mutation in one copy, it's enough to increase the risk for certain cancers. So how are these genes passed on from one generation to the next? So what I have here is an image of a female, an image of a male. They both have 2 copies of their gene, but the male has 1 copy with a mistake or mutation on it, denoted as that red area. Now, when they go on to have kids, mom's going to pass on either one gene or the other. It doesn't matter. They're both working just fine. But the father, one of his genes has a mistake or mutation. And so when they go on to have children, there's a 50% chance he passes on the gene with the mutation, 50% chance he passes on the gene without the mutation. We call this a dominant form of inheritance, where if an individual has a genetic mutation, there's a 50% chance it can be moved on or passed on to the next generation. Now, genes are gene mutations can happen all throughout our body. When you go out in the sun and get a sunburn, there's mutations in all of your skin cells. And sometimes these mutations are so severe that your body says, hey, we have to get rid of them, and your skin peels off. And so there's this balance act, because lots of gene or cells that never once had a mutation, they may develop them over time. And that's how all cancers occur. Therefore, all cancers have a genetic origin. Really, what this image shows is how a normal cell, for example, a normal prostate cell, if it accumulates a mistake or a mutation in a cancer-protecting gene, then it can start, kind of going rogue or deviating. It no longer fully identifies as a prostate cell. Now it's kind of its own little selfish group of cells that start just collecting resources. And as they grow, more mutations happen in different parts of this tumor. And you end up getting this, what was once a cluster of prostate cells now becomes this tumor that has all these different gene mutations inside of them. And so that's the natural history of the natural way with which cancer happens. Is a very a normal cell will just by chance accumulate mistakes and mutations that puts it down this trajectory of becoming cancerous. Now, I say that because that explains why most cancer happens. We call this sporadic cancer. Cancer that happens, I call it by bad luck, by chance. 70 to 80% of cancers happen this way. 70 to 80% of cancers are like lightning striking. But there could be cancers that are that occur because of some kind of an inherited genetic predisposition. If there is a mistake or a mutation in a gene that protects us from cancer, some of these cells might actually have a higher chance of going down that slippery slope. And that accounts for about 10 to 15% of cancers, hereditary. familial cancers are the genetics world's fancy way of saying, well, there's definitely something going on that's increasing risk in this family, but it's probably too complex for us to really understand. And so we say there's something going on, but we don't necessarily know what. So how is testing even done? We talk a lot about genetic testing, but nowadays, there's different types of genetic testing. And some people will say, well, yeah, my prostate cancer had genetic testing. And other people will say, well, they took a blood sample from me and did genetic testing. Those are the two basic, ways that we do testing, but they test for different things. So most commonly, genetic testing is done using a blood sample or a saliva sample. Truly, it doesn't matter which sample we use. All that we're looking for is just some type of tissue that a person has, and we're looking to do a genetic test on the cells in that tissue to see if there's a gene mutation. So whether we use blood or saliva, we're actually just looking at white blood cells. So it's really just testing the bone marrow. We could do a skin biopsy too, but that's pretty invasive. And we're testing the cells, the white blood cells, to see if there's a mutation. And if there is a mutation, we say, okay, well, that mutation is probably present in every single cell that person has. And we would say that includes their sperm cells. There's a 50% chance they pass this gene mutation on. If there is no gene mutation there, we say, okay, well, maybe this person got cancer for other reasons, happened by chance or sporadically. The other type of testing we do is actually from the prostate biopsy itself, or we call these liquid biopsies, where we're actually looking at cancer tissue and we're doing genetic testing on that. And we'll always find something. Cancer is full of mutations. And so we always find a huge profile of gene mutations when we test tissue. And the reason why we test it is because it can give some physicians insight on how to treat someone's cancer. We call that personalized medicine. Honestly, all medicine is, pretty personalized, but this is, really just focusing on the specific mutations a person's cancer has and trying to target that cancer by doing that. So we call that tissue testing. The other one we call germline testing. Germ cells are sex cells like eggs and sperm, and that's where the mutation is. And so it's present in every one of our body, because we get half of our genes from mom's egg, the other half from dad's sperm. And so when we do this germline testing on people, there's some indications where we see a high rate of these gene mutations. And in the world of prostate cancer, these are individuals who have prostate cancer that's spread to other parts of their body. We call that metastatic prostate cancer. And this huge groundbreaking study happened in 2016, where this individual took 700 men who had prostate cancer that had spread, did genetic testing, and find that about 12% of them have some kind of a gene mutation. That's huge. And so in Canada, where I'm hoping that most clinics, if someone has metastatic prostate cancer, is offering genetic testing looking at some of these genes. I know in BC that's the case. I know in Ontario that's the case. I know in Quebec it's case by case. And so different provinces have different rules, but I'm hoping that as a country we can align on this one indication for genetic testing when someone has metastatic prostate cancer. So here are some of the genes in that pie chart, and I'll talk a little bit more about them as well, because there's some specific features about these that I think are pretty interesting. But the world is constantly changing. And so 2 years later, another study came out and said, hey, well, people who have this specific type of pathology, when doctors look at their prostate tissue under the microscope, they say, yeah, there's something a little bit special here. They call that intraductal or ductal pathology. One study said, yeah, these men also have high rates of prostate cancer gene mutations. And then 3 years later, another study came out and said, no, I don't think that that's actually true. And so I bring this up to say that science is always changing, and what we know is only based on what knowledge is available to us at this time. And in years from now, things can change. But the world of prostate cancer genetics is changing quite rapidly. When someone approaches genetic testing, we sometimes think about, what about life insurance, critical illness insurance? Could they discriminate against someone if someone does have a genetic predisposition? They can't. We have a federal law that prevents these companies from accessing or using our genetic tests against us, but they can still use your personal history against you. They can still use your family history against you when it comes to that discrimination. I set a timer just to see how I'm doing for time. So we talked about these hereditary pieces, but I want to focus a little bit on the familial piece. We know that 5 to 15% of cancers can be attributed to this. And so what this chart shows is an RR, or a relative risk, risk relative to the general population. So a man who has a brother with prostate cancer, that man's risk for prostate cancer is 3.4-fold higher compared to the general population. If a man has a father and a brother with prostate cancer, that man's risk for prostate cancer is 5-fold higher. It's a huge genetic risk. We don't know necessarily the genes that are associated with it. We do know that family history is a big predictor of someone's risk themselves for getting prostate cancer. Another cohort of individuals who are at elevated risk for some genetic reason are individuals of West African and Caribbean ancestry. Now, what do these two geographical locations have in common? The slave trade. And so we have two populations that are in different parts of the world that one originated the other, and we see a higher rate of prostate cancer. What I have here is a heat map where the red shows rates of mortality or death due to prostate cancer, and the cooler colors, blues, are the decreased or lower number of mortality. And again, in this geographical area, we see West Africa and the Caribbean as these high mortality rates. And we start wondering, is there something genetic in this geographical location that's increasing risk? Maybe just socioeconomic or other factors may not be enough to account for this discrepancy. Maybe there's something inherently genetic, but we don't know too much about that at this time. The last thing I want to focus on are what's called heritability. And this is a way that we study individuals' risk by comparing twins. We look at identical twins versus fraternal twins. And if an identical twin gets prostate cancer, what's the chance that his other twin is going to get prostate cancer? Versus fraternal twins, they're like brothers. They don't have the same genes. What's their rate of getting prostate cancer? And what we identified is that men with prostate cancer, if they have an identical twin, that identical twin is very likely to get prostate cancer as well. It means there's something in their DNA that's increasing risk. In fact, prostate cancer is more heritable than ovarian cancer or breast cancer, even though we think about these cancers being quite genetic. Prostate cancer might be more genetic. The issue is that we don't know a lot about these single gene, single cause mutations. We call that monogenic. That maybe isn't accounting for a lot of why prostate cancer happens. Maybe prostate cancer is more polygenic, multiple genes increasing risk. We just are really bad at this time in doing polygenic testing. So I want to focus on these monogenic factors. What we have here is a chart that has a list of a whole bunch of acronyms. These are genes. HOXB13 is the only prostate cancer gene. Greatly increases risk for prostate cancer, but we don't know whether or not prostate cancer ends up being more aggressive. So that's one of the genes that we test for when we do germline testing. BRCA1, BRCA2, made famous by Angelina Jolie, is also a gene that increases risk for prostate cancer. BRCA2, prostate cancer will get aggressive unless it's treated and managed. If it's let to do its thing, it will ultimately become quite aggressive. Other individuals with gene mutations are Beyonce Knowles' father. He has a BRCA2 gene mutation. And this gene was identified by Mary Claire King with a bunch of other physicians, including Stephen Narod, who's at Women's College Hospital in Toronto, where I'm affiliated with. What they realize is this condition is actually called hereditary breast ovarian cancer syndrome. Men don't have ovaries, men have very little breast tissue. And we wonder whether or not this name and this association of breast cancer with the BRCA genes is accounting for the discrepancy in men who get testing. 1/10 of men who have 1/10 of people with gene mutations who get testing are men. And so there's kind of this question, should we call it King syndrome as opposed to hereditary breast and ovarian cancer syndrome? But then again, it gets more gendered towards men, but an interesting kind of aside. Lynch syndrome, another set of genes that can increase risk for prostate cancer. Lynch syndrome is also connected to colon cancer, uterine cancer, stomach cancer. And some of the gene mutations in Lynch syndrome can cause more aggressive cancer. ATM, like the ATM machine, is another gene that increases risk. 1% of Caucasians have a mutation in this gene. And so for men with prostate cancer, sometimes if they're on active surveillance, ATM might be a predictor that they might not do as well on active surveillance, and maybe be a good piece of information to know to say, maybe we should be more inclined to do treatment as opposed to following an active surveillance plan. CHEK2, another gene that increases risk for prostate cancer, not CHEK1, but CHEK2. When it comes to treatment, when we do genetic testing, there's a little bit that we know in terms of how we can manage risk. For BRCA2 carriers, we think about You know, perhaps an individual might be a better candidate for surgery because we could do a full pathology review. When it comes to active surveillance, is BRCA1 carriers and ATM carriers, should they be on that for as long? Should they be followed differently? The thing is that it's kind of the Wild West. We don't really know yet. There's not any major recommendations. This part of medicine is still being refined. What there is more insight into is that if men do have metastatic cancer and they have one of these gene mutations, there are therapeutic options available. For BRCA1, BRCA2, and ATM, if someone has a germline mutation in that, or a mutation in their tissue in any of these genes, they may be candidates for PARP inhibitors. If a man has Lynch syndrome and has prostate cancer, he may be eligible for these PD-1 inhibitors as a form of more systemic therapy for prostate cancer. And so I guess the take home is that if a man has metastatic prostate cancer, he should be asking about genetic testing. Genetic testing can give information not only for him about potential treatment, but he inherited these genes from mom or from dad. He could pass them on to children, and siblings could have these gene mutations. And if so, a gene mutation identified in a man could have implications, definitely has implications for the family as well, and can give them this preparedness to say, okay, well, if I'm at increased risk, let me screen more carefully. For women, some of these genes increase risk for breast and ovarian cancer, and can give insight for children's daughters, sisters, parents, cousins, aunts. That's what I want to talk about.
Wow, that was great. Thanks, Justin. Thanks for making something that's really complicated. Thanks for explaining in a way that I can understand part of it, because I'm pretty stupid about that. So that was great.
Murray,
Yep.
can I ask him a quick question here before he heads out? If my dad had prostate cancer, my husband had prostate cancer, we have 2 sons.
Mm-hmm.
Should they be genetically tested?
Yeah, I think it's a good question. So if we're looking for a genetic mutation that's causing a health condition like prostate cancer, the person most likely to have that gene mutation is the person with the health condition. So if we're ever going to offer genetic testing, the best person to test is the person with prostate cancer. And if they have the mutation, then we test children and other family members to see if they've inherited that gene mutation. So we always start with the person who's most likely to have the gene mutation. Once we find it, we then know who to test and how to test.
Awesome, thank you.
And so anybody can ask their treating oncologist whether they're eligible for genetic testing, and their treating oncologist can refer them to a genetics clinic.
Great. Thanks, Justin.
No worries.
We're going to move on.
Okay.
We're going to move on to the future. Looking to the future, what's on the horizon is the next topic, presented by Dr. Michael Cox, Senior Research Scientist at the Vancouver Prostate Center, and who also sits on the board of Prostate Cancer Foundation BC. Dr. Cox is a molecular and cellular biologist who earned his PhD in biochemistry from the University of North Carolina for studies on how oncogens impact neuronal growth and differentiation. He began his work on cell signaling networks in prostate cancer at the University of Virginia. His research program is dedicated to understanding how prostate cancer, the most frequently diagnosed male malignancy, initiates and progresses, and to finding ways of halting advanced disease progression. Welcome, Dr. Cox.
Sorry about the bio.
No
Everything
worries.
is shared, I presume. Okay, so thank you all for coming. I don't see my slides, but that's okay as long as you guys do. It is my pleasure to be here. And yes, I do sit on the board of the foundation, and they do help support some of the work that goes on in my lab. I also sit as a member of the Advisory Council for the Canadian Cancer Society, and they have funded some of my work in the past as well. I'm not going to talk about any of that in any detail today. So
sorry,
yes,
I actually can't see your slides.
Oh, I got to share. I got to manually share.
Yes, please.
Okay.
Thank you.
So while I'm sharing, Justin, thank you very much for that wonderful talk. Setting us up like that, that really did help a lot. And it's going to, I think that will help in people understanding some of the things I'll be saying as well. So now everything is okay, right,
Perfect.
Rochelle?
Yeah.
Oh, good. So I was handed this title, Looking to the Future, What's on the Horizon? And so I hope that I can address some of those issues here today. If I can figure out how to advance my slides now. There we go. So One of the biggest areas of growth in management of prostate cancer has been the understanding and use of active surveillance for men with low risk prostate cancer. This sort of conservative management is clearly on the rise. And I show you a blurb from a recent American Urologic Association annual meeting poster that described over a twofold change in the use of active surveillance for men with low risk prostate cancer. And really, this comes out of a lot of the work that's come from Canada, Laurie Klotz and many others, like Goldenberg and people throughout the world. And the idea is that we know enough now about prostate cancer, the spectrum of the disease, that we can, with high confidence, predict which men don't need objective therapies. So what is low risk prostate cancer? Typically, it's scored as a PSA of less than 10, where the disease is graded as group 1, or in the old school, Gleason 6, 3+3, and is staged T1 to T2A. Active surveillance is a process of monitoring that patient and monitoring his prostate, looking for any changes in disease status that might trigger the need to go ahead and have objective therapies. So regular PSA testing and MRI-guided biopsies are the norm. MRI imaging, once biopsies have been done a few times, what we're seeing is the emergence of various disease-specific imaging techniques that are PET imaging techniques and SPECT imaging techniques. PSMA-targeted gallium and fluorine are leading the way right now. And so those will be coming on as more and more PET devices become available throughout the country. And then, as we just heard, molecular testing is really important to understand not only what the patient's inherited predispositions are, but also to understand what kind of mistakes, what kind of genetic changes have happened in the cancer itself, and if any new ones occur as it goes on, because the cancer does evolve over time. So out of Ontario, we have a nice study of this early phase of active surveillance that indicated that 52% of men remain treatment-free at 5 years once entering an active surveillance cohort. And as time goes on, this value will be more improved from various sites and across and around the world, and we'll understand really how well men do when they're on active surveillance. The downside here is that there is quite a bit of dropout. So the median time to treatment was 16 months. So that means that's the middle. And so when guys presented, the next time around they had a biopsy or something, their disease was upgraded, upstaged, and either they had more disease or some more high-risk features were found in the new biopsies. The emergence of ideas that we just heard about, that Justin just talked about, like intraductal carcinoma, those are indicators of more aggressive disease, and certainly are triggers for using objective therapy, surgery, and radiation therapy. There are many mitigating circumstances to using active surveillance. We'll never see 100%. If you're young at age of diagnosis, that tends to not make you a good candidate for active surveillance, unfortunately. Comorbidities, typically in the way of urinary dysfunction, blockage, and that sort of thing, those need to be managed. Family history, healthcare access barriers, people that are way away from being able to get to healthcare regularly are not necessarily good candidates for active surveillance. If PSA changes really fast, or there's a high volume of tumor, even if it's a low-grade disease, is still an indicator that therapy is warranted. And then patients have C-word aversion, and so there are many times when that becomes the trigger, and as you guys know, they say, "No, doc, get it out." And so surgery and radiation are always options. So is 60% enough? It seems like it should be, but there's clearly evidence from other places where active surveillance has been used a little bit longer that we can even maybe see as high as 80%. And I think that in an era when PSA testing is being used more judiciously and with better ideas behind what's going on, I think that we can do a better job with that. I don't know what I just did. Here we go. All right. So prostate cancer, as you guys all know, is this dynamic thing that takes a lot of time. And so from the time of primary therapy, radical prostatectomy or radiation therapy, for those 20% of men or so for whom that isn't curative and their disease starts to come back, typically they'll be offered something like radiation salvage therapy. And if disease continues to increase, then first-line hormonal therapy, androgen deprivation therapy, plus or minus taxanes, docetaxel are typically used. After a period of remission, those few guys that continue to progress can be offered salvage radiation therapy, second-line androgen receptor pathway inhibitors, immunotherapies, DNA repair therapy, some of the things that Justin just talked about, followed by chemotherapy, and so on and so forth. And so right now, we have quite a number of agents that are modern and actively used in the clinic. And the majority of them are androgen pathway inhibitors. And you can see a list here. And these are because androgen receptor signaling is the primary driver of prostate cancer growth, as far as we can tell. We have a variety of other therapies that target different activities. We have immunotherapy. Provenge was the first approved immunotherapy. We have ways to treat bone disease with rank ligand monoclonal antibodies like denosumab. We have radiotherapies, a number of them. Alpha-radin is a simple, small radionuclide that homes to bone and can help deal with pain and get some relief there. And then second-line taxanes like cabazitaxel are in active clinical use. And as we also just heard, the use of PARP inhibitors or inhibitors of DNA repair defects are really amazing agents that are being used not just as monotherapies, but in combination therapies. And that's probably what I'll try to focus on most as we go forward. The other thing to remember is that as new therapies are approved, they're always approved at late stage disease. And what we're seeing is a phase migration, and these therapies, once they're approved, can then be used earlier and earlier in disease course with an effort to try to find combinations and sequences that can be more beneficial, if not curative, for patients with specific types of prostate cancer. So the androgen receptor pathway will remain the mainstay therapy target. And this is the driver of the disease as far as we can tell, as I said earlier. And we have a number of ways that we go about targeting it. And while many of these have been around for quite some time, there continue to be improvements because not all drugs are equal. Improved ability to keep drugs in the body's bloodstream, improved activity against their targets, all kinds of things come into play when developing evolutionarily new agents to go after the same old targets. So we have a number of agents that go after luteinizing hormone receptor hormones or gonadotropin releasing hormone pathways between the hypothalamus and the pituitary that stops the production of sex hormones that drive production of testosterone in men, estrogens in women. And those are really important for the growth of the prostate and the prostate cancer. We have a number of really potent anti-androgens now that have made bicalutamide look like aspirin. And so those agents are very actively used. We have steroid synthesis inhibitors, abiraterone and TAC-700 are the two lead agents, and those do a very good job of stopping production of steroids from extragonadal sources. And then again, in certain patient populations, particularly those with limited access to healthcare services, surgical castration is still used. So prostate cancer, as we know, increases with burden over time. And Dr. Huggins earned a Nobel Prize for demonstrating that androgen receptor pathway inhibition results in a regression almost every time. He also recognized, and we are well aware, that in a percentage of men, disease progresses regardless of that androgen receptor pathway inhibition. Since the introduction of all these new, very potent agents, we've seen a migration of the disease from being, I have a pointer here, hold on a second. Here we go. From being androgen receptor active, this green area, in the pre-maximal androgen blockade time, that's what this acronym stands for, to the post-maximal androgen blockade period. And so what we see is that there's a decreasing percentage of men that are dying with androgen receptor active disease, but it's still the dominant part of the disease spectrum in men that are succumbing to prostate cancer. What we do see is an increase in percentage of men dying with disease that has either neuroendocrine activity as a characteristic, or we could call them euphemistically double negative, where they don't seem to have neuroendocrine or adenocarcinoma characteristics. They have characteristics of just being a bad acting cell. And so we have to understand what those phenotypes are and how to best address those as well. So disease plasticity is a major issue. And so we're going to have to continue to work on that and understand that that's going to be a major target as we progress with continued maximal androgen blockade. So this is one example of data coming out of my lab. Prostate cancer has a unique feature in that when it metastasizes frequently to bone, and in about 80% of men with metastases have bone metastases. And when it metastasizes to bone, unlike most other cancers, it tends to form more bone. We call this a sclerotic lesion. And so I show a couple of examples here of some sclerotic lesions. Some, as in A, have residual network of bone fibers that tend to hold the bone together and cause that nice network of material that we have that allows us to flex and be strong. And then inside of it, a bunch of new bone forms. Or we have situations where the residual trabecular structures are actually all resorbed, and it's filled with this disorganized bone matrix that is being caused due to the influx of prostate cancer cells. And we can see that pretty clearly in a zoom in of one of these areas with residual trabecula in this area here, and then the new bone forming in these areas here in a very disorganized way. And so this is a specimen that had been preserved for quite some time. And when we look at fresh specimens that we collect from patients that are undergoing surgery to manage bone fractures and that sort of thing, we can see that those voids are filled with prostate cancer cells. And in this case, we're showing evidence by staining for a marker for the cells of origin, their cytokeratins and prostate-specific membrane antigen, which I'm sure you guys have heard a good bit about, and I'll go ahead and tell you a little bit more today. So when prostate cancer goes to the bone, there's a dynamic interaction with the cells that are in the bone environment. And we call this the vicious cycle. So prostate cancer cells put out factors that activate cells that absorb bone, osteoclasts, and that these cells are part of the everyday management of bone homeostasis. And these cells, when they're mining this material, release factors that seem to be good for the prostate cancer cells to grow. These cells, along with the prostate cancer cells, also influence the cells that lay down bone. And these are called osteoblasts. And we're very interested in how some of these sorts of things happen. So we have therapies that go after the osteoclasts and either to strengthen the bone with bisphosphonates or inhibit the activation of the osteoclast by denosumab to inhibit the rank ligand. We also have agents such as alpha-radin, this radium-223, that acts as a radiotherapy that homes to the matrix of the bone, and by decaying and giving off radioactive particles can kill prostate cancer cells, but also kills other cells that are in that environment as well. And I see a future where we will stop worrying so much about the osteoclastic activity and focus more on this abnormal bone formation that we see and the osteoblast and the interaction between the cancer cells and these osteoblasts that allows them to form all this aberrant pathologic bone. PSMA targeting is now and the near future for sure. There are a number of agents that are being developed and are already in use to go after PSMA as an imaging and a therapeutic angle. So we have agents such as lutetium-617, that is a radionuclide that when used can home to prostate cancer lesions. And when lutetium-117 decays, it gives off particles that can kill the surrounding cancer cells. We also have PET imaging agents for diagnostic purposes and for monitoring purposes, gallium PSMA-11, and this fluorine labeled molecule as well that I don't want to try and say. So these are all very actively being used. A number of other activities to target PSMA or other surface markers on prostate cancer cells are in the works, but in the near future, again, what's on the horizon are immunotherapeutics, again, that Justin just referred to. Things like CAR T cells or CAR NK cells, and bispecific and trispecific agents that allow activated T cells to be recruited to the prostate cancer in order to invoke an anti-tumor activity by the person's own immune system. So in prostate cancer, as I said earlier, the first approved immunotherapy was Subtilis T, which was a type of vaccination made from a patient's own antigen-presenting cells, and to activate T cells and B cells in order to build up a repertoire of self-immunity to go after that person's prostate cancer by going after prostate-specific. Hello, my dog has just come to visit me, so we'll see what she has to say. But the other sorts of approaches that have been tested have really not come to much fruition. We do have immune checkpoint blockades that have been used successfully, particularly in things like melanoma and more in lung cancer, where the cancers have a high metastatic burden. But prostate cancer is considered a relatively immune cold tumor. While there are lots of mutations, they don't have anywhere near the mutational burden of something like melanoma or lung cancer, because they're just not exposed to the same sorts of causative agents, sun and tobacco smoke, for example. And so a number of these agents that have been tried in those other indications have been tried in prostate cancer. Anti-CTLA-4 has not proven very successful in prostate cancer, but there has been a little bit of success so far by targeting this immune checkpoint PD-1, which is a way that cancer cells and tumor cells interact in order to tell themselves not to kill each other. And so blocking that allows an activated T cell to actually be able to kill a cancer cell. So CAR Ts are really phenomenal technology where a patient's own T cells are removed. They are then engineered so they express a chimeric receptor for something that we know is on their prostate cancer, such as PSMA. And so once that receptor is built, those cells are then expanded and infused back into the patient, where these cells now can home to the cancer cell, bind to it, and then if those immune checkpoints are inhibited, then those T cells can then kill those cancer cells. And these have been successful mostly in blood tumors in pediatric indications, but there is a real effort to try to get those to work in solid tumors and in adult indications as well. And so I show you this one example of a paper that has recently been published on a PSMA targeted CAR T, where they built in some other agents to protect the CAR Ts from exhaustion by protecting them against a variety of other agents that are in that tumor microenvironment. And so this is the kind of thing that I expect to continue to evolve and that we'll see in the over the near horizon as a new therapeutic. Convincing the patient's own immune system to kill off his cancer is the very best way I think we can possibly go. Other ways we can do that, again, is still just trying to get the immune system's natural killing capacity to find a tumor cell, identify it as something that's foreign, and then kill it using the techniques that it has at its disposal. And so these are T cells and natural killer cells. And so another way to get those T cells and natural killer cells to bind to the tumor is to create a linker, a bridge. And so there are bispecific and trispecific reagents, bispecific reagents that bind tightly to a receptor on a T cell or an NK cell that also have a modality that binds tightly to the tumor cell, such as a PSMA binding agent. And so those things would then bridge the T cell to the tumor cell, and then the T cell would be in a place where it could then turn around and attack that cancer cell. It can find it because it's drawn to it by this new magnet. A trispecific agent is another way to actually more tightly bind that magnetic agent, if you want to refer to it that way, to a immune cell, and then bring it to the cancer cell in order to drive it. You can also develop it so that you have multiple targets on the tumor cell, such as STEAP1 in PSMA has been an idea that we've been kicking around in our group. So there are lots of genomic changes in metastatic prostate cancer, some inherited, some develop as disease progresses. We know that most metastatic castrate-resistant prostate cancer have actionable mutations, and that many of them are inherited, but many of them evolve as the tumor develops, and that there are some, this 20-something%, that have really easily targetable mutations. So the three that have caught the most attention since this first landmark paper from Robinson in 2015 have been targeting something we call the PI3 kinase pathway, a key survival signaling pathway in all cells. The androgen receptor pathway, of course, continues to be a hot topic. And then DNA repair, as Justin referred to earlier. So I'm going to give you a list of some ongoing combinatorial trials that are going on that I think have a chance to produce new ways to treat and manage prostate cancer in the very near future. So the first are continuing to work with these DNA repair defect targets. So PARP inhibitors are being used in combination with inhibitors of steroid synthesis, anti-androgens, and these are underway. The idea being that you can increase that ability to kill those cells as you force them to make mistakes while they divide. There are a lot of immune checkpoint targeting approaches. I said that PD-1 was doing anti-PD-1. This Pembro is doing a really good job in many other cancers and has shown some promise in prostate cancer, but nothing that would really make it a single agent. And so there are a number of trials such as these 5 listed here, in which it is being combined either with things like DNA repair defects or anti-androgens or chemotherapy, or even targeted agents such as tyrosine kinase inhibitors. In the bone metastasis space, the questions remain how to go about that the best. Right now, radium-223 is still the lead way to go about trying to resolve bone metastases by irradiating those, and whether or not that can be done in combination with other therapies such as anti-androgens like enzalutamide remains to be seen. I think it's really a good idea to be able to do that, because what we find is that these metastatic lesions in bone tend to be androgen receptor driven, and that men that develop these other types of disease, these double negative or neuroendocrine diseases, they tend to have metastases in soft tissue like lung and liver. So the bone mets appear to be the classic way this disease has evolved, and it remains androgen receptor driven. So going after androgen receptor in the presence of these other compounds is a good idea. And then there's the emergence of PI3 kinase signaling pathway inhibitors. This idea is not new. It's been around as long as I've been in the field. What's new is really effective agents. And so new inhibitors of an enzyme that we call AKT have been developed, and they are currently being trialed. They should be very effective, especially in men that carry lesions in a tumor suppressor we call PTEN. And so we look forward to seeing how these agents move forward in the context of anti-androgens or anti-steroid synthesis, and in combinations with other therapies as well. And just recently, ESMO has just reported, and there's some very good signs coming out of a couple of these, the PROPEL and the Keynote 365 trial, that's showing that there are signs of overall survival benefits as a first-line therapy for patients with metastatic castrate-resistant prostate cancer. So that's this trial up here using olaparib and abiraterone. And Keynote 365 is showing promising anti-tumor activity in chemotherapy-naive prostate cancers. And so that's this one here with Pembro, this anti-PD-1, and this anti-steroidal abiraterone. So in conclusion, better stratification of low-risk patients and use of active surveillance management helps men avoid the consequences of objective therapies without impacting life expectancy. Androgen-mediated signaling remains a primary target for disease management at all stages, so that's not going to go away over the horizon. Therapies approved for late-stage disease are being used earlier and earlier in disease progression, and that is the immediate future. Aggressive androgen receptor pathway targeting does give rise to a reproducible, recurrent type of androgen receptor pathway independent prostate cancer or cancers. And we are learning more and more about the characteristics of those types of cancers and ways that we can specifically target them in a personalized management way. The agents targeting specific genetic alterations are providing customized therapeutic options for patients at all disease stages. And These numerous advances in diagnostics and treatment are substantially reducing disease mortality. And so, in the context of this forum, I would be remiss if I didn't say that the future has to hold improving psychosocial support for men and families living with, not dying from prostate cancer. This is a major unmet need. So thanks all for listening.
Thanks, Mike. Just speaking personally, as someone who's living with prostate cancer and who has a son, I just want to thank you because your talk gives me some hope for him in his future. So to finish off our day, we'll be turning it over to a radiation oncologist and a urologist to answer your most asked questions. Dr. Neil Dwyer, urologist, received his medical degree at Memorial University in Newfoundland and then completed his urology training at Dalhousie in Nova Scotia. After this, he traveled to Iowa City, Iowa, and trained in reconstruction and incontinence. He has been a staff urologist in Moncton, New Brunswick for the past 17 years. His practice is in general urology, and he is the reconstruction urology for New Brunswick and often in PEI and Northern Nova Scotia. He's active in most aspects of prostate cancer care, from diagnosis to surgery, management of erectile dysfunction, and stress incontinence. Dr. Juanita Crook is a radiation oncologist at the BC Cancer Agent Cindy Aluwalia Hawkins Center for the Southern Interior, pioneer in the field of brachytherapy research and past chair of the American Brachytherapy Society. Dr. Crook studied biology at the University of Toronto and trained in radiation oncology at Princess Margaret Hospital, followed by a postgrad fellowship in Créteil, France, outside of Paris. Upon returning to Canada, she began working in Ottawa in the first Canadian brachytherapy program. Dr. Crook went on to establish a successful program for prostate brachytherapy at Princess Margaret Hospital before bringing her expertise to the BC Cancer Agency in Kelowna. She continues to focus her time on high-dose brachytherapy for both prostate and breast cancer. Welcome, Dr. Dwyer and Dr. Crook. Sorry.
Okay, well, I'll start off here, and Dr. Dwyer and I are very happy to be able to address some of your questions. We got a lot of questions. Many of them were of too personal or specific in nature to be able to directly answer without more information, but we managed to group them into various categories, which I think will cover a lot of the ground. Concerning how to make the diagnosis of prostate cancer, waiting for treatment, side effects of surgery, side effects of radiation. These were both frequently asked. What about hormone treatment? How do you cope with it? How do you tell if you're cured? So we'll proceed with these now. In terms of diagnosis, you have to keep in mind that the diagnosis of prostate cancer can only be made by biopsy. MRI and other forms of imaging are done for staging, to clarify the local extent of the disease within the prostate and if it has spread. Now, we can be like 99% sure that someone has prostate cancer if they've got an elevated PSA and the digital rectal exam's abnormal, or from what we see from MRI, but we can't know the grade of the cancer, the Gleason score, how aggressive it is, and therefore decide what are going to be the best treatments without a biopsy. So biopsy is not going away. And the CUA has approved MRI prostate as a screening tool for elevated PSA. So you can have your MRI first and then only go on to a biopsy if the MRI suggests that that's important. So we wouldn't be relying just on the PSA level. Next.
Dr. Crook, I think we lost Dr. Dwyer. So
he's muted. No, wait a minute. Where is he? We lost him? Okay, yeah. Well, okay, I hope he's okay. I'll carry on. A few people did ask about active surveillance, and Dr. Cox has dealt with that in some detail. And basically what this means is no treatment for now. And we recommend this for men with a favorable risk prostate cancer. That means a Gleason 6 or less, PSA under 10, early stage T1 or T2, which is very unlikely to spread or reduce life expectancy. We can also consider active surveillance for older men if for Gleason 7 cancer, especially if they've got other health problems, which may be more significant for that individual. So if the cancer doesn't pose a risk, it's very reasonable to avoid the side effects and risks of treatment. And this is often what patients choose. Next. So how do you watch it? Checkups regularly, digital rectal exam with your urologist, repeat PSAs every 3 to 6 months. We do need repeat biopsies. You can't trust just one biopsy, usually within 18 months. And if that doesn't show anything worse, then every 2 to 4 years. And we are also looking now at MRI to guide biopsies and measure progression of disease in men who are being watched. Next slide. So this is an example of an MRI. And you can see a normal MRI here on the left. This is a normal peripheral zone that is pale white. And here you can see that pale white peripheral zone has a gray blot in it here, circled in blue. And that's the cancer. And this is what multiparametric MRI allows us to do. So we can measure it, we can follow it. And that gives us much more information than just the finger and a PSA. Next. When are you going to get treatment? Sometimes the patient is just sick of waiting and it's their choice. They say, no, I'll forget it. I can't sleep. Go ahead. But if the PSA is going up, growth of cancer on the prostate exam, upgrade on biopsy, or progression on MRI. And Dr. Cox went through these things with you. Next slide. So we'll move on now to radiation. There's various types of radiotherapy. People were very specific, like, why can't you tell me what my particular risk of side effects is? Well, it depends on the type of radiation, it depends on the fractionation, it depends on the structures are contoured, it depends on you, your health, your other health conditions. So there's a lot of things that go into that. So external beam can be given in a standard fractionation, which has been used for decades, which is usually 2 gray per day. Hypofractionation, which means a larger daily dose, but a smaller number of treatments. Or internal radiation, which is also called brachytherapy, which can be either a seed implant, which is the classic type, which has been around for 25 years, or a temporary implant, which is the high dose rate type. I left out stereotactic body radiotherapy by mistake, and this is also a form of external beam radiation, but a much larger daily dose and very few treatments. Next slide. So external beam, almost anyone with prostate cancer can receive external beam, any risk group, any Gleason, any age, any health status. However, brachytherapy, the internal form of radiation, has proven better long-term outcomes than external beam. So brachytherapy is often going to be recommended for men who are in good general health and are able to have it. If they have a higher risk tumor, a more aggressive tumor, we would combine the brachytherapy with external beam radiation. The other big consideration of whether you'll be offered brachytherapy is if it's available in your center. They have to have the expertise. Next slide. That just shows a linear accelerator on the left, and then the kind of dose distribution that you can see. You're not going to see my arrow here because it's not my screen that's being shared, but that blue outline of that shape lining the pelvis, that's the target, that's where the lymph nodes are, and the yellow ball at the top is your bladder. And so having a full bladder when you have your treatment is like having a balloon in your pelvis, which pushes the bowel up out of the way and spares you toxicity in your bowels. So that's why you're always asked to have a full bladder. Next slide. The radiation side effects are going to vary from one individual to another. They cannot be precisely quantified for any individual, even when you know all the details. It's going to depend on the method of delivery, the dose of radiation. I can tell you in general that the VMAT and IMRT types are much better tolerated than the older 3D conformal because they modulate the dose of radiation as it's going through your body to maximize it at the place where we want it to be delivered. Brachytherapy, the internal radiation, is the most conformal. It's also the highest dose. So you're going to get more urinary irritation in the short term than you do with external, but the long-term efficacy is higher. Bowel symptoms during radiation can be helped by a low-fiber diet and psyllium, and this is otherwise known as Metamucil. And this is what your oncologist is going to tell you about in your weekly visits. Next slide. So just to give you some examples of doses and why this is confusing and why we can't just give one simple answer, an LDR seed implant brachytherapy. delivers 144 gray in a single treatment, but delivers it very, very slowly over 6 months. The high dose rate brachytherapy is actually a much lower dose. It's generally only 27 gray, not 144, but it's given in 2 treatments, but those treatments only take a few minutes, not over 6 months. So that's why the radiobiologic effect is very, very different. Conventional dose radiation, which I mentioned uses the 2 gray fractions, is generally given over 7.5 weeks with a dose of 78 gray. If you give a slightly higher daily dose, you reduce the dose to 70, but you reduce the number of treatments to 28. So the treatment duration is only 5.5 weeks, or sometimes 60 gray in 20 treatments over 4 weeks. And these are all calculated radiobiologically to have a similar efficacy, but it's a calculation. And stereotactic body radiotherapy is the most confined and adventurous in the external beam realm. And that can sometimes be given in just 5 fractions over 2 weeks. It's not given every day. Usually it's every second day or a couple of times a week. So that's the range. So all radiotherapy is not the same. Next slide. We'll quickly look at the brachytherapy. The seed implant, as I said, is very conformal. We deliver it using transrectal ultrasound. The number of seeds depends on the size of the prostate, anything from 65 up to 120. Next slide. These are placed permanently into the prostate with the patient under anesthetic. For favorable risk, it's very effective, can be used by itself, but most of these people will be watched. Intermediate risk, it can also be used by itself. And high risk, we combine it with external beam radiation plus hormonal treatment. And this is for spatial cooperation because the brachytherapy can only treat the prostate. If we have to treat the lymph nodes or the seminal vesicles, then we need to combine it with the external. Next slide. And this, as I said, is a 1-day procedure, 1 hour under anesthetic. You go home 2 or 3 hours later, you recover quickly. Sexual function as for surgery is going to depend on your age and the function at the time of the procedure. There's about a 15% loss in the first year, and then age-related decline will continue as the years go by. But this type of treatment is an excellent long-term cure with undetectable PSAs out to 10 years and beyond. Next slide. HDR is very similar to an LDR procedure, but the radioactivity doesn't stay in your body. We just put in a scaffolding of needles and a single seed traverses each of these needles in turn, pausing in the required places to deliver the desired radiation dose. And that takes about 20 minutes. So it's given very, very quickly. Next slide. And this just shows the scaffolding of needles through the prostate on the left side of the screen. And then those needles are connected with their own individual transfer tubes to the machine that holds a single radioactive source, which is 10,000 times stronger than the seeds we put in permanently. And that delivers the radiation. Then we disconnect everything, pull out the needles, and you're done. Next slide. Surgery. Over to Dr. Dwyer. I think he's reappeared.
I am here. Can you see me and hear me?
Yes.
Okay, I don't know if I'm on video. I can see you, Juanita, but they can't see me. So I look just like her.
We can see you, Dr. Dwyer. You're good.
Okay. Okay. So first off, I want to apologize. We've been on the phone with our internet supplier a few times today, and they reset it apparently just as I was waiting. And when I was being introduced, I lost all my connections and I had to go to my phone. So I'm holding my phone in my hand right now on cellular data to make this work because my Wi-Fi has come back, but it's too late to get back in. So let's talk about surgery. Can you go back one slide? Nope, that's forward. There we go. So in surgery, there's basically 3 main types. We have the robot, which is on your left. Then we have laparoscopic, which is in the middle. And then we have open, which is on the far right. And lots of differences between them, but they're all small technical things. With respect to outcomes and everything that matters, there's no significant difference. These surgery types have been around each for greater than 10 years. And there's been numerous studies in all types. And the bottom line is that there's no definitive papers that show one is better than another. What is definitive is that the surgeon should do the one that they're best at doing. Otherwise, that's all that really matters. Next slide. So how to prepare. I'm just going through, when I prepared these things, I thought of what questions you guys had asked and looking at that. So a lot of things, how can we prepare for surgery? How can we prepare? One of the big things, and this is a little unfair because when you're being told you have cancer, but bottom line is, as a surgeon, healthier people and people who are fit do better. And the biggest ones there are the same things your family physician hopefully talks to you about, like with respect to diabetes and obesity. Surgery is harder technically and on the person if they're less healthy when they come in. And there's a difference between a perceived level of health and what's actually healthy. Another thing that we recommend and we do routinely at our hospitals, we have all patients trained on pelvic floor exercises with a nurse continence advisor, and they're introduced to what this involves and what to expect. So they have a session with a specialized nurse prior to surgery so they know what they're getting into and what to do when the surgery's over, even with respect to having a catheter and stuff like that. On the last note there, basically, what do you do once you've made the decision? Stay active, stay fit, and get your sleep. These are the key things in preparation for surgery. Next slide. So all forms are equally effective. The one advantage of surgery, if there's an advantage of any option, is the fact that when you do surgery, especially as we're now dealing with higher risk cases a lot, we have the option of adjuvant radiation in higher risk cases, which means the radiation is done immediately after, or salvage radiation at a later time. Some of the details, again, addressing the questions asked, is that even with open surgery, I used open is because most people think of robotic and laparoscopic as a much less invasive surgery, but really the short term is pretty similar to the patients. Even with open surgery, they're generally home within a few days. You'll see American data talking about 1 day, but they have a different way of measuring time. You have a catheter drainage for 10 to 14 days. You have a drain in that makes sure everything heals up for a day or two. And you're basically back to full activity at 6 weeks. Of course, when you're back at 6 weeks, it's not like being 30 and you're out of commission. When you're 60 or 65 and you're injured and out for 6 weeks and then come back, it's going to take a while to get back to full activity, but you're released from restrictions at that point. What can we do in the surgery? Well, the surgery can alter how we do the surgeries based on the pathology, and that's the biopsy pathology and the MRI. If we have an MRI or a pathology that suggests a more aggressive cancer, then we do different things. If it's more tight cancer, well contained, we can do nerve sparing. If it's more aggressive, we can do wide resections. Just waiting for the voice there. We can also do large prostates, or if there's a prior prostate resection, then we can actually do these in surgery without having any major issues. Of course, there's a few extra risks with that. I'm just waiting for the words to go away because it's covering the last of my slide because I'm on a phone. There we go. With respect to open surgery, it's a midline incision. The reason I mentioned this is one of the questions that talked about a parallel incision. All incisions are midline. You add up all the incisions done for laparoscopic, robotic, or open. They're all about the same length. It's just the midline one in open surgeries. They're right through the center. Next slide. Can I have the next slide? There we go. So I'm going to change my view here so I can see better. So let's talk about the complications. The complications can be broken down to 3 major categories. Early complications involve blood transfusions. The risk statistically is about 5 to 8%. It does depend on the center you're in, and it also depends on your preoperative hemoglobin. So someone who comes in a little lower is going to have a higher risk. There is no advantage to directed donations. If you do directed donations, you're more likely to get a transfusion. A risk of infection exists. Everyone gets antibiotics. There's a risk with catheter issues. Major injury, such as nerve injury to major nerves that control leg power, or rectal injury, is less than 1%. Most of us in our career will see 1 or 2 of these. That's hopefully all you see. Intermediate, meaning in timeline here, we have bladder neck scars. They occur often less than 5% over in the first 3 months. And then long-term, the ones that we're going to talk about more in a second are the ones most people are interested in, erectile dysfunction. The simplest way to think about this is the best determiner of successful erections after surgery is your erection success prior to surgery. There's a natural history at play, and surgery is the ultimate equalizer as to what's going to happen. So whatever we do, we cannot improve where you were. It's always going to be a little worse. So nerve sparing surgery does offer you some advantages with respect to having increased chances of success with therapy. But if you have an aggressive cancer, if you have a Gleason 8 cancer, if you have a cancer that looks like a T3 on an MRI, which means it's bursting through the pseudocapsule, then these cancers we can't nerve spare, because it's the paradigm of surgery is success in the surgery for cancer control, then it's continence, and then it's erections, because these are the things that are going to affect your quality of life the greatest in that order. With respect to incontinence, it's prior bladder issues. These are important. Obesity, again, diabetes, and again, more aggressive cancer means bigger resections. Let's next slide. So looking more specifically at the side effects with respect to continence, if you look at data, and data is great when it applies to a group, and I'm talking like this, but when it's talking to an individual, it's not as effective. So the statistics would show you that 90 to low 90% achieve very happy control within 1 year. But the big thing is it's over a year, so it's a journey, not a race. Everyone in the beginning has incontinence. Sorry about that if that came through. Everyone has incontinence in the beginning. There are things we can do to limit that, and that's pelvic floor exercises. Weight control, again, is a critical thing. There are surgical options. I'm a reconstruction urologist by training, which means that I deal with the complications of surgeries, other people's surgeries and my own. And they have great success rates, and these are surgical interventions. The other thing is to compare yourself with similar aged people. So when people are leaking at 65, you have to think of your 65-year-old friends, not your 30-year-old self, because most men who have not had prostate cancer, 65 to 70, have BPH or enlarged benign prostate. And those men tend to have pre-void urgency or get up at night or some post-void dribbling. So they're not peeing perfect at that age, no matter what. You can't compare yourself to the perfect person. And higher risk surgery or higher risk cancer with scars, so you have a higher chance, of incontinence if you have scars and more aggressive cancer. Looking at erectile dysfunction, basically start the rehab as soon as you can. The rehab is simple. It's pills first, so all the pills that everyone knows about, vacuums, needles, and the bottom line is use them. There is evidence that the longer you go without any use, the more likely to form permanent scar, and that's in anything. You'll see improvement for up to 2 years, and I always like to give the story to my patients that you'll see a shift where nothing works, and you go from pills to needles, and then over time they start to have some spontaneous erections, so they go back to pills, and then after that they may see spontaneous erections without pills. But that's not everyone. That's just the perfect outcome. But it's going to be, again, a journey. You can do a penile prosthesis if all fails. They are very successful surgeries. They're answering the question specifically. A dry orgasm is what men will experience, but orgasm is not lost. The nerves for orgasm are very different from the nerves for the penis, and they're not affected by this surgery. They're rarely affected in most physiologic conditions. There's a higher risk of erectile dysfunction with age, because age correlates most strongly with erectile dysfunction and more aggressive cancer. Next slide. So what can you do after? Start pelvic floor training as soon as you can, penile rehabilitation as soon as you can, exercise and stay active, and maintain your healthy weight and lifestyle. Next slide.
Okay.
You want to take this, Juanita?
Yeah, sure. So as you may well be aware, androgens are hormones that promote male characteristics. Testosterone is the main androgen, and prostate cancer cells need androgens to grow. This is what Dr. Cox was referring to. I mean, de novo prostate cancer is androgen sensitive. When it becomes resistant to that, it's called castrate resistant, and that's when you have to branch off into different forms of treatment. So we can, when someone presents with a newly diagnosed prostate cancer, using androgen deprivation to block the production of testosterone starves the prostate cancer. So it's most often used to treat cancer that's spread outside the prostate, if it's recurrent after another treatment, or high-risk cancers, we combine it with radiation in order to get better results. Next slide. Why is it combined? Because multiple large randomized trials involving literally thousands of men in North America and Europe have shown that for advanced or aggressive prostate cancer, when you treat with radiation, you go with a radiation-based approach, the results are better when it's combined with the androgen deprivation. So that means more men are cured, fewer men die of prostate cancer, fewer men have it spread to their bones. I mean, every endpoint you look at is better if you go through this period of androgen deprivation prior to and during your radiation. Next slide. Side effects. This isn't a walk in the park. It's not chemo. You're not going to be sick, but it affects a lot of things. The side effects, hang on a second, sorry. The side effects include hot flashes, weight gain, loss of muscle mass, decreased bone, sorry about that. Decreased bone density, erectile dysfunction, thinning of the bones, cardiovascular events can also affect your mood, your energy level. You have to know about the broad scope of the side effects that you're going to get from this before you go into it so that you have a game plan on how to address it. Next slide. One thing that I find a lot of men think they're receiving estrogen. No, you are not receiving estrogen. Estrogen was used to treat metastatic prostate cancer way back, 30, 40 years ago, but not anymore. What we do is specifically block your testosterone production. And this is reversible within a few months of stopping those drugs. So what you need to do, you need to stay active or get active. These are the same thing that Dr. Dwyer was just saying about the surgery. Exercise will preserve your muscle mass and your bone strength. Exercise reduces stress and improves mood. You take vitamins D and calcium to ensure the bone strength is maintained. Exercise helps avoid the weight gain that comes along with androgen deprivation. In order to also prevent the weight gain, a low-fat diet's important. Try to avoid full-fat dairy products. So I usually spend 15, 20 minutes talking to people when they're going to go on this stuff and give them a whole printed list of things they're supposed to do. And if they're listening and they do it, they often come back 3 months later and say, I've never felt better, which is surprising since they no longer have any testosterone, but I should have done this 20 years ago. They've lost some weight, they're getting more fit, more active, it's improved their mood. So yeah, you can counteract a lot of the side effects of the lack of testosterone. Next slide. Another big question is, am I cured? And I'll deal with the radiation question, and then we'll go back to Dr. Dwyer. So definition of cure after brachytherapy has only recently been established, and that's a PSA less than 0.2 4 years after treatment, or 4 years or more after treatment. And most men after brachytherapy, as they go on to 10 and 15 years, will have a PSA of 0.0 something. After external beam radiation, they don't define cure, at least they haven't tackled that yet, but failure is defined as a PSA that's risen more than 2 points from its lowest reading, 2 nanograms per mil. So how long do you need to be followed with PSA? No matter what you have, whether it's a radiation-based approach or a surgery-based approach, essentially forever. More frequently at the beginning, and generally after 5 years, only annually. And a lot of people, some people ask, well, what can be done? Can I get more radiation if it comes back? The radiation dose is calculated to be the highest possible to achieve cure while respecting the tolerance of adjacent normal tissues and keeping serious side effects under 5%. So radiation generally will not be repeated if it doesn't work the first time. Next slide.
So when we look at surgery and we look at how we define cure, generally after surgery, because the prostate's missing, you have no PSA. So the PSA should remain undetectable. And I've outlined at the first there part of my slide exactly what Juanita was talking about. We do the similar thing, more intensely follow up in the beginning. Some of it's regarding PSA every 3 months, then every 6 months. And a lot of it's also to do with the dealing with the patient and the implications of the surgery, dealing with the quality of life. So more intense in the beginning. And then as time goes, it's generally a 5-minute visit to look at the PSA. And then most patients are discharged at 5 years back to the primary provider with PSAs for life. The PSA should remain undetectable. There's a lot of different microassays. These are even in where I live in Moncton. I have another hospital down the street. They have a different assay to me. I have another hospital across the border. They have a different one. So the bottom line is when you start to see a rise, we always recheck it. Once we see a couple of rises, whatever the rise is, it's significant in surgery. So that's when we start talking to our radiation colleagues, because if it does start to rise, they may be a candidate, depending on the timeline, for adjuvant or salvage radiation, which is another chance to actually cure the cancer. Next slide.
So what we've tried to explain here is there's no one answer for everyone. And people will say, some of the questions were directed towards, well, what treatment is going to give me the best quality of life? Well, that's going to depend on what you value most. Is it sex, continence, spending time with grandkids? Do you just want to be alive no matter what the price? It's something you need to discuss with your urologist and radiation oncologist. And the best treatment is going to depend on the characteristics of your cancer, your priorities, and your health. So this is a two-way street, or three-way sometimes, if you've got a multidisciplinary situation where both the urologist and radiation oncologist are involved, and with yourself. So, and the other thing about prostate cancer is you generally have enough time to research your options, think about it, discuss them, and come to a decision. You don't have to decide on the first office visit, well, this is what I want to do, because there's no need to rush that much. Neil, do you have anything else to add there?
No, that was excellent. I missed my beginning, which I was going to make a comment. I hope you emphasize my line that medical students do not do surgery. I hope you said that with some grit, because I put that in. That was a comment that came up a few times. Never happened, never will happen. So that was all I want to make sure they knew.
Thanks, Dr. Crook and Dr. Dwyer. And I wanted, you guys had the toughest job trying to answer those questions, and you did a great job dealing with it. So thanks very much. First thing I want to do is, well, first of all, I just want to thank everybody, all the speakers, for their great presentations, and thank all of you for attending. And then I want to just turn it over to Rochelle for just a minute, and she wants to talk about the expo, and then we'll finish things off for the day.